Hello and good morning, everyone. My name is Dr. Brian Ramnaraign. I'm a medical oncologist at the University of Florida Cancer Center, where I specialize in the care of patients with genitourinary cancers. On behalf of the University of Florida Cancer Center, as well as the Judy Nicholson Kidney Cancer Foundation, I want to welcome everyone to today's symposium and thank you for choosing to share your morning with us. Today's meeting is entitled A Celebration of Hope, a Kidney Cancer Educational Symposium. The main goal of the meeting today is to help educate patients and caregivers about kidney cancer and answer questions they have but may not have had the opportunity to ask. Today's meeting is meant to empower patients and caregivers, as we believe that knowledge is power, and patients with better knowledge of their cancer can make better decisions regarding their care. We need to remember that kidney cancer is a very common cancer. The American Cancer Society estimates that there will be about 76,000 new cases of kidney cancer this year in the United States, and about 14,000 people will die this year of kidney cancer. There are an estimated 583,000 people living with kidney and renal pelvis cancer in the United States currently. Kidney cancer is the sixth most common cancer in men, and the lifetime risk for a man to develop kidney cancer is about 1 in 46 or 2%. For women, kidney cancer represents the eighth most common cancer diagnosis, and the lifetime risk here is about 1 in 80 or 1%. For those of you who may not know, the kidneys are an extremely important organ. The kidneys, of which we have two, are the bean-shaped organs attached to the upper back wall of the abdomen and protected by the lower rib cage, one on each side. The main job of the kidney is to remove excess water, salt, and waste products from the blood, and in doing so creates urine. However, the kidney has other jobs as well, and that includes helping to control the blood pressure, as well as helping the bone marrow to produce more red blood cells. When cancer develops in the kidney, there is usually a single mass that grows within the organ. However, sometimes there are two or more tumors within the same kidney, and other times there are tumors in both kidneys. The most common type of kidney cancer is renal cell carcinoma, for which there are several subtypes, and other cancers can develop in the kidneys as well, including transitional cell or urothelial carcinomas, renal sarcomas, or nephroblastoma, also known as Wilms tumor, which almost always occurs in children. We must also remember that there are non-cancerous or benign tumors that can form in the kidney, and those include angiomyolipomas or oncocytomas. While we don't know exactly what causes kidney cancer, risk factors for this disease includes a history of smoking, obesity, chronic high blood pressure, treatment for kidney failure, specifically being on dialysis, being of older age, and having a family member with a history of kidney cancer. Certain inherited familial syndromes are associated with kidney cancer, and those include the von Hippel-Lindau disease, Birt-Hutchinson syndrome, tuberous sclerosis, and others. However, inherited kidney cancer only represents about 5% of all kidney cancer diagnoses. When kidney cancer is caught early, surgery is often curative. However, in advanced stages, treatment with surgery, systemic therapy, and or radiation therapy is only palliative. Over the last few years, we have seen tremendous strides in the treatment of kidney cancer. New treatments have been discovered and approved by the FDA that have led to our patients living longer with better quality of life. We hope that this trend can continue, and new options and therapies for patients are certainly on the horizon. Today's speakers include a variety of doctors from the University of Florida Cancer Center, from a variety of specialties, who are all deeply involved in the care and management of patients with kidney cancer. Dr. Padraic, a urologist from UF, will discuss current advances in kidney cancer. Dr. Sara Falzarano, one of our genitourinary pathologists, will discuss renal cell carcinoma. What about the pathology report? I will follow and speak on a topic near and dear to my heart, and that is the role of immunotherapy in kidney cancer. Dr. Jonathan Chatzkel, my colleague in medical oncology, will discuss treating kidney cancer with VEGF therapy, and he will go over the oral therapy options that patients can pursue. Dr. Abdullah Malkawi, a University of Florida radiologist, will discuss imaging in kidney cancer and the imaging studies we perform that are essential to the patient's staging and care. Dr. Paul Crispen, another one of our University of Florida urologists, will speak on the surgical considerations for kidney cancer. Dr. Jess, Delaune, one of our colleagues at the Gainesville VA, will discuss the diagnosis and staging of kidney cancer. Lori Bumbaco is a nutritionist, and she will discuss the nutritional aspects of cancer care. And last but not least, we have Jayla Barnes, a nurse practitioner, who will discuss tools for coping with the cancer diagnosis. Our goal is that today's presentations and discussions will serve to answer some common questions that patients and caregivers have regarding their care, and we hope that today's symposium can be used as a springboard to elicit further discussion between patients and their doctors. Once again, our objective is to empower patients in a celebration of hope. So without any further ado, I will pass the baton on to my friend and colleague, Dr. O'Malley, to start things off.
Thanks everyone for joining. My name is Padraic. I'm a urological oncologist in Department of Urology at University of Florida. Thanks for the opportunity to be here today and talk about something that I'm very passionate about and do a lot of work in, and I hope you find it educational and informative. All right, so we'll go ahead and get started with our slides. All right, so I'm going to talk a little bit today about kidney cancer and some of the advances we've made throughout the sort of field as a whole. Some of these areas are going to be touched on by my colleagues in greater depth later on in the day. And this sort of talk is a bit of a preview of some of those, really remarkable advances that have been made. I'm also going to touch a little bit on sort of earlier stage kidney cancer and small renal masses a bit more, so that's not really going to be covered later on. And so we'll go ahead and start with that. Okay, advance. Here are some of my disclosures. None of these actually have any implications for what I'm going to talk about today, but there they are. So the objectives for today, I'm going to spend just a little bit of time talking about the epidemiology, or how many people really are affected by kidney cancer. And then, as I mentioned, we're going to talk a little bit about those small renal masses, and then touch on some of those other areas of more advanced disease, and that will sort of lead into some of the discussions I'll be had later on today with some of the other presenters. So kidney cancer is quite common, over 76,000 cases in the last year, and it's common to both men and women. So it is more common in men than women, but both genders are really affected quite a bit by this. And over time, we've seen that this is a type of tumor that has risen in prevalence. It increases every year. The average age of most patients diagnosed with kidney cancer is in their mid-60s, but we certainly see patients who are much younger, and we also see patients who are much older. The 5-year sort of cancer-specific survival for people who had really localized or small masses is really quite good, whereas those who had metastatic disease traditionally has not been great. But you'll see some of the talks later on will show how that's actually been improved significantly in the last few years. So this is just some data from actually the UK. It kind of reflects the patterns we see in the US and other developed countries, and it just shows that the incidence of these small renal masses, or in this case small kidney cancers, has increased over time and continues to do so. Some of this was because we imaged people more often than we used to, but there is an increase beyond that we are unable to sort of really hone into why that's happening. But it is a continuing to rise cancer and will become more and more prevalent. So, a lot of patients, their first experience with this really is going to be they have a scan done and someone says, well, you've got a spot on your kidney. So, most people, the question is, do I have a kidney cancer? And if so, what do I do? So here's a large list of lesions and conditions that you can have in your kidney. Fortunately, you can see that these are actually all benign masses. So these are masses that are not cancer that you can have in your kidney that can look on a CAT scan very much like a kidney cancer can. So it's important to keep that in mind. And so I say it's important to keep that in mind because just because you have a small mass in your kidney does not mean it's a kidney cancer. We know, up to a quarter of patients with these small masses, i.e. less than 4 centimeters on your kidney, a quarter of them are actually benign, i.e. they're not cancerous. Amongst those that are cancerous, we know that generally speaking, they tend to be fairly indolent. As I say, they're a bit lazy. They grow very slowly, about 0.1 to 0.2 centimeters per year. And the risk of spreading somewhere else is actually very, very low. It's really less than 2% in the vast majority of cases. So, many of these masses, certainly in older patients, may not actually require any treatment or intervention in your lifetime. Certainly in younger patients, we tend to be a little bit more proactive, but that's because you, generally speaking, have a longer time for these to actually start to become a problem. But either way, you're not really in a rush to have to do something about it right away. So when we talk about small renal masses, there's a number of different options. We can do what's called active surveillance. And that's basically the process whereby instead of intervening with surgery or radiation or anything like that, we really just keep an eye on these and watch them, as we know that many are not going to change. We have what are called ablations. We can do this by either cooling the tumor, so freezing it, or heating it up, cooking it. And so these are called cryoablation or radiofrequency ablation. And you can see here, it's basically like having a freeze gun for these tumors. And then even surgery has changed significantly. Most surgeries now in the small renal masses are performed robotically, and you can see how that sort of looks on this model here. These are basically small little incisions with instruments that then do the work inside the abdomen rather than the traditional open incision. So, Dr. Crispen will talk a little bit more later on the day about surgery and a little bit more about what's involved with that. So when I talked about these being very slow and very lazy, you can see that, a quarter of these are benign. They are very slow growing. And we also know that the 5-year cancer-specific survival, i.e. the chance that 5 years from now you are not dead from this, is basically 100%. Right? These are not, generally speaking, killers. And there's been multiple studies that have shown that. So it's a fairly consistent result. Again, that does hold true for lesions less than 4 centimeters by and large. It has not been validated for larger masses. We know that larger lesions will grow a little quicker. Their ability to sort of spread elsewhere and metastasize is a little bit higher. But in some situations, in some select patients, even if your mass is greater than 4 centimeters, it still can be an option for very carefully selected patients. But generally speaking, it's not the usual treatment for those patients. So as I mentioned, a quarter of these are benign. So, still not convinced that watching is the right thing for you. We can add in a biopsy. I will say and make a very strong point about this. For some reason, there is some sort of perception in the public that, once you do a biopsy, if the air gets to these cancers, they can spread. That's simply not true. There's no evidence to support that. In fact, the evidence shows that, biopsy is extremely safe. And this risk of spread really does not exist for these small lesions when you do the biopsy. And if you didn't need more convincing, kidney cancer, these small masses, is one of the only top 10 most common cancers in men that is not diagnosed by a biopsy, and one of only 3 in women within the top 10 that is not diagnosed based on a biopsy. So, we really, by bringing patients to surgery or treatment, we are over-treating a large number of people, and it'd be nice to know what exactly we're starting with before we go in and do interventions to people. The biopsies are very accurate. About 94% of patients, we will get a sort of an answer that sort of tells us exactly what we're dealing with. And we know that can significantly change what patients will do. That can sometimes be, it'll make some patients who are leaning towards surgery now not have to have surgery. Some patients who may not have had surgery are a little more inclined to have surgery. So it does change the management in about 30 to 50% of patients. And I'll sort of put in a plug at the end of the presentation today just about a trial we are starting up here. And the main goal of the trial is to see how often does it really change the management in patients. So ablation, as I mentioned, this is kind of like our freeze gun. We use cryo, which is freezing, rather than the heating radiofrequency ablation. This is done primarily here by our radiologists, where they go in percutaneously or through the skin. There are other ways you can achieve this, but the percutaneous for us, we find works the best. It works ideally for those lesions which are about 3.5 centimeters or less. It's extremely effective, 92 to 96% effective. There are some limitations, and that's mainly based on the location of those lesions. If your spleen is extremely close or your pancreas is extremely close, your small bowel, sometimes we can't freeze these. But by and large, it's very well tolerated. Most patients will have the procedure done and go home the same day. If they have a lot of medical issues, we may keep them overnight, one night. And as I tell many patients, if you have the procedure done on a Friday, you can be back to doing cartwheels on the Monday. So you can resume your normal activity very quickly after these procedures. So surgery, Dr. Crispen is going to talk about this a little bit more later on. It is certainly the most definitive and the most accurate treatment modality. But it's also the most invasive, so it's got the highest risk associated with it because it is the most invasive. And, you know, the rates are quite low for these complications, but they can be significant when they happen. So it's important to keep that in mind. Generally speaking, if these lesions are less than 4 centimeters and there's no invasion of blood vessels, it's by far the most effective treatment modality at 98-99% effective at 5 years. So although it may be invasive, it does work very well. But with these treatments, you know, because they're effective, you're unlikely to ever need any additional treatment, but it is also the most likely to impact your renal function because it is more invasive. Here's a picture of how you normally perform these surgeries now with the robotic surgery. This is a Da Vinci robot. This is the latest version where you have these small little port sites. So you can see why the recovery with that is quite quick. This is sort of the traditional approach. This shows sort of an open procedure. You can see the surgeon's fingers there and the electrocautery device he's using there to sort of remove that tumor. That is sort of the more traditional way. There are some benefits that we still use this in certain patients, but by and large, most patients have this done robotically. So traditionally, you know, people have this in their mind that an open procedure means this big, large incision on the left. By and large, that's not the case unless someone has a very large tumor. This young lady's abdomen here, where she has a much smaller incision, is, you know, the more de rigueur now if you do have an open procedure. But clearly that's still bigger than these small little incisions with the robot. So when we can, we like to do these robotically, but we can still have a good outcome even if we do these open these days. So overall, with small renal masses, the survivability is extremely high. Not all of these are even cancers. Biopsy is a safe and accurate means of gaining more information. And in some patients, they may not need treatment. Surveillance may actually be the best approach for those. In those patients who do opt for treatment or who would benefit from treatment, ablation and surgery are both good options with overall really quite low complication rates. So Dr. Chatzkel and Dr. Ramnaraign, and also a bit Dr. Delaune, are going to talk about systemic therapy in renal cell carcinoma, and this is really in the metastatic setting. I do want to point out that, you know, I try and get away from using the term chemotherapy in kidney cancer. Chemotherapy is like a nuke. It destroys everything, the good stuff as well as the bad stuff. The therapies we use now, which they will talk about later on, targeted and immunotherapy, are much more like a smart bomb. They're much more precise, much more sophisticated. Because of that, they tend to be better tolerated, have a lower side effect profile. They certainly can still have still have side effects, but they do tend to be much lower than traditional chemotherapy. Some of these agents are even given orally. Some are still given IV. But the other thing is, because of how smartly designed these drugs are, they can act not just in one place, but on multiple targets in these tumor cells. Next slide. So again, you know, traditionally having metastatic kidney cancer was not a great diagnosis. That is a sort of historical number you see there, that 12% being alive at 5 years. Fortunately, things have really changed, and there is good reason for hope. And my colleagues will talk about that later on. I think this is one of the big success stories in kidney cancer currently. In metastatic kidney cancer, currently we are using a combination of immunotherapy, targeted therapy, and surgery to try and sort of optimize outcomes for these patients. If we had a wish list, I think one thing we're trying to still figure out is the optimal time in the surgery, and also, can we prime people's immune systems either with a combination of these drugs, surgery, and even radiation. Dr. Ziltecki will probably touch a bit on the radiation aspect later on. And we're also looking through clinical trials that we have, such as Padraic, looking at how do we stack these different therapies to sort of get the best outcome for our patients. And that's why these trials are really extremely important, because they are how we are advancing the field and really changing the outcomes for kidney cancer patients. So I'll touch briefly just a bit on these locally advanced disease. These are people who neither have these small masses or have had spread somewhere else, but think of them as sort of a ticking time bomb. These are larger masses. They tend to be more aggressive. It is only a matter of time before they do spread somewhere else. And we see that some of these patients do well at 5 years. Some will have an 85% cancer-free, and some do not do very well. Some will have a 35% cancer-free rate. And part of the reason for this is that this is a real mixed bag of tumors. We can see here there's two very different lesions here. The top panel, this lesion is much more localized and sort of confined to the kidney. And in the bottom panel, we see this sort of larger heterogeneous mass, which is a much more concerning appearing picture radiographically and clinically. So that's why there's that 35 to 85% spread. It's quite wide. So, we have looked at, can we use things like chemotherapy and stuff in these cases where we know there's a high risk for it coming back? And we've tried looking at them before surgery and after surgery. And unfortunately, we've not seen a survival benefit. So here's a panel. These are all the studies that were done trying to use these drugs before surgery, none of which were any benefit. And then here we see this is a list of trials where we tried to use drugs after surgery. And unfortunately, there was no benefit in survival. And so, we've really not seen any benefit from using these systemic therapies for these more advanced cases. But that was before the advent of these immunotherapy drugs. It's important we do clinical trials, because many of these patients, who don't have spread, I feel like, many of them are left waiting and hoping for the all clear when they come to their appointments. For many of them, they know they have a high risk, but there's a loss of empowerment, and that can have significant psychological and quality of life effects. I think one of the other presenters today will talk a little bit about this, but that can be a real bother for many patients who, if they had an opportunity, would love to optimize their chances to, live a longer, happier life if they could. I think we are on the cusp of things changing in this region. This is a trial that we accrued patients to here at University of Florida, the PROSPER trial. And this is using these newer immunotherapy drugs. And in this case, patients either got surgery, which is the standard, or they got immunotherapy before and after surgery. This trial is completed. We just now have to wait and see how patients do. We are very optimistic within 2 or 3 years we'll have the results of this, and that it will really change the landscape. But that's, again, the importance of these clinical trials. So, locally advanced kidney cancer, it's due for a game-changing study. I think a lot of that will be learning how to use the immune system to our advantage. And irregardless of, what drugs we use, what surgery we use, what radiation we use, it really is important to have multidisciplinary and multimodal care. So it takes, the surgeons, the medical oncologists, the radiation oncologists, the radiologists, the pathologists, who really work close together to really drive this field forward. And because of that, we're getting better and better at treating patients. So I'll just end here with a sort of a little prop for our trial that we're hoping to start this fall. This is the renal mass biopsy trial. Otherwise abbreviated the RAMBO trial. And this is a trial being done for these patients with small masses where they undergo a biopsy. And we really want to see how often does it actually change the management of these patients. As part of the study, we're also looking at patient's urine, their scans, and also genomics on these biopsies. This would be the first study of really looking at genomics of these small masses to try and predict how they behave. And, with the urinary biomarkers, this is with a colleague of ours who looks at sort of proteomics in small molecules in the urine. It would be great if all we had to do is a urine test to sort of tell you whether or not this was a cancerous lesion or not, and what you need to do about it. But again, this trial is a multidisciplinary approach. We're hoping to open that in the fall. And so if you're fit into this group or you know someone who does, keep us in mind. Thank you very much for your attention and give me the opportunity to talk to you today. Enjoy the rest of the day, and hope you enjoy the rest of the presentations.
Good morning, everybody. My name is Sara Falzarano, and I'm a clinical associate professor of pathology at the University of Florida, Gainesville, with subspecialty training and heartfelt commitment to and interest in genitourinary pathology, including kidney cancer. In the next 20 minutes, we will talk about the renal cell carcinoma pathology report and what goes in and what comes out of it, touching upon its role and potentially my role in the management of a disease, like in this case, renal cell carcinoma. So let's talk about the renal cell carcinoma and how does the pathology report work in the context of your cancer care. In the next 20 minutes, we're going to talk about the pathology report and the elements that are included in the pathology report, what goes in to make a pathology report, and its role, and if you will, my role in the management of a disease, like in this case, renal cell carcinoma. The pathology report is a medical document which is curated, signed, and released by the pathologist. We, the pathologists, are doctors who specialize in the diagnosis and classification of disease by looking at tissue and/or cells under a microscope or performing an equivalent digital microscopic examination of tissue, and by interpreting medical laboratory tests. The tissue is obtained from patients through different methodologies, including biopsy procedures, such as upon inserting a needle in an organ and withdrawing a cylindrical sample of tissue, or surgical excision, or even larger, more complex resection procedures, in which the tissue of interest and/or entire organs are removed and sent to the pathology laboratory for processing. In pathology, every piece of tissue that is received for examination is called a specimen. And specimens are given a unique number so that they can be followed as they move through the laboratory. The number is associated and is matched to the patient's identifiers, such as date of birth, name, and procedure date. The processing entails several steps, all of which are crucial for generating the accurate and complete pathology report. From the close examination of the specimen, which is depicted in this slide, to the microscopic slicing of tissue blocks that are obtained from sectioning that specimen and reducing it to small fragments of tissue that are put in these cassettes over here. And they're sliced into thin slices. You can see here 4 micron is a very thin, almost bidimensional image of a once upon a time tridimensional type of specimen. And an H&E slide, a methoxylin and eosin stained slides, this pink colored slide, is produced after all this processing, and finally sent to the pathologist for examination under the microscope. The pathology report of a surgical specimen, particularly large cancer resections, may be quite long and complex, and it's often divided into subheadings. They include identifiers, clinical information, gross description, an optional microscopic description, final diagnosis, synoptic template reporting for cancer resection specimens, and optional comment sections. Other information are included, such as the physician information who submitted the specimen, the pathologist who is going to release the report and sign out the report, and the address of these physicians. This slide here illustrates a de-identified example of a kidney resection pathology report from our laboratory, for instance. As you can see herein, the report includes all the required elements and more for the tissue examination and reporting. Let's go through them one by one. The first and utmost important part of the examination of a specimen is matching the patient identifiers with the specimen number. And these identifiers and specimen numbers are reported in the pathology report, oftentimes at the top of it. The general identified information include the patient name, the birth date, the medical record number, which is issued by the hospital, the date when the biopsy or surgery were done, which is the collection date, and the unique number of the specimen, which is assigned by the laboratory and called accession number or surgical pathology number. The next field includes the clinical information, which is a little bit of the patient information that are provided by the physician who submitted the tissue sample. And also the specimen site and laterality, if applicable, means if an organ is situated right or left, or if a tissue was taken from the right or left side of the body of the patient, this may be indicated in the pathology report, as well as the procedure. So the biopsy, the resection, in this case, for instance, a radical nephrectomy of a kidney, of a right kidney. The very next most important part of the pathology report is the gross description, which is the narrative of how the specimen looks on the naked eye, means seen without a microscope, and describes what the pathologist sees by simply looking at it or feeling the tissue or measuring the tissue sample. It includes information such as the size, color, number of tissue samples, and when appropriate, the weight of the specimen. It also details and lists what portions of the specimen are going to be selected and examined under the microscope, and this is the block list. A gross examination of a biopsy tissue sample may be very short, not very detailed. But a gross examination of a resection specimen, particularly a cancer resection specimen, may be quite lengthy and complex because it has to provide a number of information for the pathology diagnosis. The next field that we need to talk about, and it's probably the most important field in the whole pathology report, is the final diagnosis field. The final diagnosis is basically the bottom line of the tissue processing and the testing procedure, although it can be at the bottom of the top of the report, like in this case. The diagnosis helps your clinician decide the best treatment options, and some diagnoses may be very short, concise, like acute appendicitis or chronic cholecystitis. But cancer diagnoses are usually more complex because they have, again, to provide a number of information for the best next step in management. So if the diagnosis is cancer, this section will report the type of the cancer and will usually include the cancer's characteristics that are important for prognosis and further management. For instance, the subtype of tumor or cancer, like in this particular case, you can see here renal cell carcinoma is the type of cancer, which is the malignant tumor that derived from the renal cells proper. And the subtype is a chromophobe type, and it's an entity, a type of tumor that is determined by the certain cell characteristics and features of growth. And it's usually associated to molecular alterations and also clinical behavior, so prognosis. The grade is the second most important element of the pathology report and is determined by applying specific criteria to the microscopic features of the tumor. And it's very different from tumor to tumor. The grade may be not applicable. So there may be not a grading system for the tumor so for the actual tumor in examination. Like in this case, the chromophobe type renal cell carcinoma does not have a grading system that is universally accepted. And the grading system for renal cell carcinomas that we use, and you might have heard about, it's actually been found to be prognostic, so significant, only in two types of renal cell carcinomas, the clear cell and the papillary type that you might have heard about, or you may hear about it in the next talks. The next important information is the stage of the tumor, which is based on different criteria, again, depending on the organ and the tumor type. In general, though, it shows it's a measurement of how extensive the tumor is and if it has spread beyond the organ in which originated. Like in renal cell carcinoma, for instance, it depends on the size of the tumor and on the involvement of adjacent structures to the kidney, such as the perinephric fat, like the fat that surrounds the kidney, or the fat that is in the sinus of the kidney, like the bean-shaped kidney. And one more piece of information that the final diagnosis will report is the margin status. The margin is the edge of the specimen that has been resected by the surgeon. And the margin can be positive, which means that the cancer is present at this edge, or negative, which means that no cancer was found on the other edge. The cancer specimens, resection specimens, include usually a summary of these findings, a so-called synoptic report or synoptic template or synoptic summary, whatever you want to call it or you find it called. And this summary basically lists all of the most important findings in the case that are used to actually determine the next best in management of the cancer and to predict how the patient will do in the end, the outcome, the prognosis. They include the type of cancer found, the location and the body, the size of the tumor, information about how far the tumor has spread, the staging, right? The pathologic stage, which is a number and an acronym that is used to basically summarize all this information, and the margin status and other information depending on the cancer and type of cancer and organ. The specific items listed in the summary are those that a panel of cancer experts have decided they are essential to guide treatment and to define prognosis for that type of cancer. And they may change over time depending on results of research studies and clinical studies and trials. The other fields of the pathology report, which were not present in this particular report and are indeed optional, include a comment section and additional data. The comment section I want to talk about because it's a section that the pathologist uses to basically provide additional information for your clinician that aren't included in the final diagnosis on the synoptic summary. Sometimes, for instance, the pathologist may use this section to report results of special stains or immunohistochemical stains or molecular testing that were used as so-called ancillary testing to support the diagnosis or clarify the diagnosis. And sometimes there are diseases that are actually subtle and difficult to diagnose or controversial. And the pathologist may use this section of the report to actually express that those type of issues or clarify a concern. And also to document intra-departmental or interdepartmental consultation if the pathologist shown the case to colleagues for a second opinion. Some pathology reports also contains these additional data, including images, references, internet links, and addenda. Addenda are additional informations that are obtained after the pathology reports get signed and released to the patient. And why does an accurate and complete pathology report matters in renal cell carcinoma? Well, first of all, the pathology report information are a wealth of data, and wealth, not only for the amount of information that is provided, but also for their value. It's so precious because it definitely helps determine the next best step in management of the disease. And also, it is used to predict the outcome, which is integrated with the decision of the best next step. And finally, the pathology report matters because fighting cancer is a team effort, and we are part of that team, the multidisciplinary team that helps taking care of the disease and for deciding the best options and for the best outcome. This is the end of my presentation. Thank you for your attention, and I'll be happy to take any questions during the live session in a few minutes from now. Thank you.
Hello again, everyone. Once again, I'm Dr. Brian Ramnaraign, medical oncologist here at the University of Florida Cancer Center, and I have the honor and pleasure to talk to you today about immunotherapy in kidney cancer. Before we begin, let me describe the mission of our cancer center, and that is to prevent, detect, treat, and ultimately cure cancer while addressing the unique challenges of the cancer burden faced by the population we serve. My discussion today will be a discussion where I outline and address the following questions that are: what are the options for treatment of kidney cancer? When do we give immunotherapy? What is the difference between immunotherapy and chemotherapy? How does immunotherapy work? What are the possible side effects of immunotherapy? And how long can patients be on immunotherapy? So without any further ado, let's begin. First off and foremost, this is what a kidney tumor looks like. This image is taken from the Mayo Clinic and is a diagram, a depiction of what the kidney tumor looks like. We can see that it is fungating, necrotic, and it looks significantly different than the rest of the kidney. Now, this is a description, a graphical description of what a urologist may see when he or she goes in to do surgery. However, the diagnosis of kidney cancer is not everything. We also need to know more about the staging, as that can help with treatment planning as well. The staging of kidney cancer is determined based on the size of the tumor as well as the extent of the tumor with regards to its invasion into other vessels, such as the vena cava in stage 3 kidney cancer, or in more advanced stages, the kidney cancer can spread to the lymph nodes and other organs, and that will make it stage 4. This is a PET scan of a typical patient who may have stage 4 kidney cancer. The PET scan lights up in areas where there is higher metabolic activity indicative of cancer. The brain and the bladder light up normally, but we can see uptake in the chest and abdomen, and in this patient, this is what a stage 4 kidney cancer may look like. With regards to the 5-year relative survival rates for kidney cancer, we use the SEER data, which is a national database on patients and their outcomes. We see that with localized kidney cancer, so a tumor just localized to the kidney, the 5-year relative survival rate is about 93%. With the regional disease, so just outside the kidney, survival rates at 5 years reach about 70%. However, for patients with distant disease, so metastasis to other organs and other distant involvement away from the kidney, overall survival at 5 years is only 13%. So we have a long ways to go to improving the care of these patients with distant disease. Some considerations for stage 4 kidney cancer treatments. One of the most important points is that if the cancer has spread to other areas beyond the kidney, it is considered stage 4. Stage 4 kidney cancer is metastatic, and as metastatic, it is considered incurable. That being said, treatment options exist, which are meant to help prolong a patient's life expectancy and improve their quality of life. However, they are not considered curative. There are patients, however, who may obtain a complete response with therapy, may get back into remission, and there are some patients with stage 4 kidney cancer who may be cured, although this is a small minority. The systemic treatment options for patients in oncology, not just kidney cancer, but all cancers in general, include chemotherapy. And you may have heard of some of these drugs: methotrexate, fluorouracil, cisplatin, docetaxel. Systemic therapy options also include endocrine therapy, such as tamoxifen or leuprolide. These are used in breast cancer and prostate cancer, respectively. And last but not least, and the newest kid on the block, is immunotherapy, which has been around for the last few years and is vital to the care of our kidney cancer patient population. Now, immunotherapy is a broad and general term and can describe many different types of treatment. We have monoclonal antibodies, which are antibodies that bind to a specific protein. One of the most common is rituximab, which is a common antibody used in lymphoma. We also have antibody drug conjugates, drugs such as enfortumab vedotin, which is used in bladder cancer. This is an antibody that's bind to a toxin, so we deliver this toxin specifically to the bladder cancer cell. We also have bispecific monoclonal antibodies, such as blinatumomab, which is used in certain leukemias. And here we have 2 binding sites on one antibody that binds to the cancer, as well as to a T cell to help directly kill the cancer. And last but not least, we have checkpoint inhibitors, drugs like pembrolizumab, nivolumab, and ipilimumab, which help the immune system recover its natural ability to kill cancer cells. The focus of today's discussion is going to be on checkpoint inhibitors, which have a huge role in the care of patients with kidney cancer. Now, before we discuss checkpoint inhibitors, let's review how the immune system works. The immune system is composed of a variety of different cells. We have B cells and T cells, which make up the adaptive immunity, which is the slower response. And we also have the innate immunity, which is composed of a variety of other cells: dendritic cells, mast cells, basophils, eosinophils, neutrophils, many other cells. So it's not just one type of cell. We have a huge variety of different cells and proteins, as well as antibodies that are involved in the immune system's ability to fight off infection, as well as other functions. The organs of the immune system, of course, include the lymph nodes, which are distributed all throughout the body, the neck area, in the armpits, and groin. There are organs that are also associated, such as the bone marrow, the appendix, the spleen. These things work with the cells to help the immune system do its normal function. And we're all familiar with the main function of the immune system, which is to help fight off infections from microbes such as bacteria, virus, and fungi. However, it's not all the immune system does. The immune system is also involved in wound healing and cellular repair, as well as for fighting off cancer. Abnormalities of the immune system lead to allergic diseases, immunodeficiencies, autoimmune disorders, as well as cancer itself. How do checkpoint inhibitors work? This is a graphical description from cancer.gov. We see with the picture on the left, the yellow tumor cell interacts with the bluish-purple T cell through the PD-L1-PD-1 interaction. This interaction blocks the T cell's natural ability to kill the tumor cell. PD the T cell, and PD-L1 is a ligand that's upregulated, expressed on various tumors. So through this interaction, the tumor cell can evade the immune system. The PD-1 and PD-L1 antibodies, such as nivolumab and pembrolizumab, can bind to these receptors and ligands and block the interaction of PD-L1 and PD-1. Blocking that interaction, T cell can regain its natural function in killing the tumor cell, as displayed in the picture on the right. Some examples of checkpoint inhibitors include nivolumab, otherwise known as Opdivo by its trade name, pembrolizumab, which goes by Keytruda, and ipilimumab, whose brand name is Yervoy. The current uses of ICPI checkpoint inhibitors in oncology are vast and varied. It's currently approved first-line treatment of patients with metastatic kidney cancer, as well as metastatic lung cancer, metastatic triple-negative breast cancer, metastatic melanoma, and second-line treatment in any solid tumor patient highlight unstable or has a high tumor mutational burden. Other uses include BCG refractory non-muscle invasive bladder cancer and stage 3 lung cancer as consolidation therapy after chemotherapy with radiation therapy. This is not the list of approvals of immunotherapy in solid tumors, however, represents some of the areas where we can use it. The role of immunotherapy has been increasing in solid tumor oncology since the initial approvals in 2014-2015. Drugs like pembrolizumab and nivolumab were first used, tested, and approved in melanoma. Pembrolizumab and nivolumab were first used in melanoma all the way back in 2014 and 2015. In the 7 years since, the approvals have expanded to use in non-small cell cancer, bladder cancer, Hodgkin's lymphoma, Merkel cell, as well as certain types of colorectal cancer, and others. This discovery was so important that the Nobel Prize Committee awarded the prize in physiology or medicine in 2018 jointly to James P. Allison and Tasuku Honjo for the discovery of cancer therapy by inhibition of negative immune regulation. So what are the treatment options for patients with metastatic kidney cancer? What we have here is a screenshot from the NCCN guidelines. The NCCN is the National Comprehensive Cancer Network, which serves many roles, but in particular helps to create the guidelines to treat kidney cancer and all types of cancer. The NCCN guidelines suggest that there are 4 treatment options, at least, that we can do for our patients that are category 1 and preferred first-line options. Those include axitinib plus pembrolizumab, cabozantinib plus nivolumab, lenvatinib plus pembrolizumab, or ipilimumab plus nivolumab. Those IBs, axitinib, cabozantinib, lenvatinib, those are what we call tyrosine kinase inhibitors, and my colleague, Dr. Jonathan Chatzkel, will talk more about that later. But we can clearly see from this slide that the checkpoint inhibitors, pembrolizumab, nivolumab, and ipilimumab, are essential for the first-line treatment of our kidney cancer patients. So how is immunotherapy given? It's usually an IV infusion, and the duration of the infusion is around 30 to 60 minutes. Frequency can be as short as every 2 weeks or as long as every 6 weeks. And that really depends on the type of immunotherapy drug and the dose. And with positive responses, patients can remain on this treatment for 2 years and sometimes even and beyond that. How is immunotherapy different than chemotherapy? Well, chemo are cell death by damaging cell DNA or stopping the cell from dividing, among other mechanisms. Chemotherapy is not specific and not targeted. Chemotherapy is associated most commonly with pulmonary toxicities and gastrointestinal toxicities. And that's because, as the second point says, it's not specific and it's not targeted. Now, with immunotherapy, the adverse effects can be vast and broad. I tell that the way immunotherapy works is that it stimulates your body's immune system. And sometimes that immune system can get overstimulated. If the immune system gets overstimulated, virtually any organ can become inflamed. However, most common sites, the side effects of immunotherapy are in the skin, which may represent to the patient a rash, a gastrointestinal toxicities, which usually presents as diarrhea, which is usually a pneumonitis, a dry, non-productive cough, or arthralgias, which are joint pains and aches. On this slide, we have the distribution of the grade 1 to 2 immune-related adverse events, or IRAEs. Grade 1 or 2 represents symptomatic to very mildly symptomatic toxicities. And we can see here that the numbers range from anywhere to 5% to 35% or so amongst the various organs. The grade 3 to 5 immune-related adverse events are ones that are moderately symptomatic. Thankfully, these numbers are very low. We see here that the toxicities can be 1 to 2% of most of the organs. The most common organ, it looks to be the GI system, where with the CTLA-4 inhibitor, ipilimumab, we can see toxicity in about 11% of patients. There are even some rare side effects from immunotherapy. There are even some rare side effects from the use of immunotherapy. This is a case report from the NIH where a patient developed shellfish allergy after exposure to dual immune checkpoint blockade. So how are immunotherapy side effects managed? In the rare case that a patient develops one of these adverse events, we usually treat it with steroids. The most common is oral prednisone or IV methylprednisolone. If the patient can be managed as an outpatient, if the side effects are mild, we usually give oral treatment. However, in the case of a severe or a life-threatening adverse event, we need to admit the patient and give them IV steroids. In the case of steroids not working, which is usually rare, we would need to give stronger immunosuppressants. Now, how do we know if the immunotherapy is working? Well, your oncologist will order imaging, either CTs, MRIs, PET scans, approximately every 3 months while you're on the treatment. A complete response is defined as seeing no tumor on imaging. A partial response is when we see 30% or more shrinkage of the tumor. Stable disease is when we see no more than 20% growth of the tumor, but less than 30% shrinkage is noted. And stable and progressive disease, which we hope never occurs, is when we see more than 20% growth in the tumor. This criteria is known as the RECIST 1.1 criteria and is the most important way that we determine a response in clinical trials as well as clinical practice. Now, what do we do if immunotherapy doesn't work? The most important thing that I want everyone to remember is that patients do not fail treatments. Treatments fail patients. If the immunotherapy or chemotherapy or whatever doesn't work, it's not because the patient failed it, it's because our treatments failed the patient. In this case, we have other options, thankfully, in kidney cancer. We have targeted treatment options depending on next generation sequencing of the tumor. We have tyrosine kinase inhibitors, of which there are a variety that we can use. There are other possible immunotherapy treatments and combinations that we can try. And last, but certainly not least, we have clinical trials, especially at our center, where we are enrolling many patients in clinical trials for kidney cancer as well as other types of cancers. Now, the most recent update of immunotherapy in kidney cancer is this study and article that was published in the New England Journal of Medicine on August 19. And in this study, the authors gave pembrolizumab after patients had kidney surgery for stage 3 kidney cancer. So it was not cancer that had metastasized, it was just localized to the kidney. The surgeons took it out, and the medical oncologist gave patients either Keytruda or pembrolizumab for a year or placebo. And what the authors of this study noted is that at 2 years, there was a decreased chance of having the patient's kidney cancer come back. So this was certainly a positive study. Now, I want to make sure that I clearly mention that giving pembrolizumab or Keytruda after a patient has a nephrectomy is not part of the guidelines yet, and this is not an FDA-approved indication yet, but it was a positive study, and it was presented earlier this year at our national meeting. So for some final thoughts, immunotherapy has come a long way since its introduction in kidney cancer over the last handful of years, but we certainly have to go further. Only a small percentage of patients with kidney cancer can be cured with our current treatments, but our goal is to get it to 100%. Our goal is for 100% of patients with stage 4 kidney cancer to be cured of their disease. So immunotherapy has come a long way, but certainly there is a lot of work for us to do in the near future. My hope was that this talk on immunotherapy has shed some light onto what it is and how it works. And I hope that you all better understand how useful and how important this is to our patients. So thank you so much, and I will hand it off to the next presenter.
Thanks so much for joining us today. I'm going to be talking about VEGF inhibitors, what patients and their families need to know. My name is Dr. Jonathan Chatzkel. I'm a medical oncologist at the University of Florida, and hopefully you'll find this information useful for you and potentially for a family member.
What are VEGF inhibitors and why do we use them? VEGF stands for vascular endothelial growth factor, or blood vessel wall growth factor inhibitor. Many kidney cancers express compounds that stimulate VEGF receptors. This causes blood vessels to grow, become leaky, and dilate, in turn allowing the tumor to grow. These blood vessels are abnormal and can also help to limit the ability of the immune system to fight the cancer. Through blocking VEGF receptors, it is possible to limit the flow of blood to the tumor and cause it to shrink. These medicines can be used alone, or they can be used with immunotherapy. When used with immunotherapy, these medicines can be especially effective, and treating patients with a doublet of immunotherapy plus a VEGF inhibitor is now common. VEGF inhibitors are most frequently used when kidney cancer has spread to other parts of the body and cannot be totally removed by surgery. The goal of the therapy in this case is to shrink the tumor, help patients live longer, and delay or limit symptoms from cancer. A VEGF inhibitor called sunitinib is sometimes used after a patient has had their kidney tumor removed surgically to help keep it from coming back, although there is some disagreement about whether the evidence is strong enough to support this particular use. Some VEGF inhibitors that are used to treat kidney cancer include axitinib, cabozantinib, lenvatinib, pazopanib, sunitinib, and tivozanib. Your doctor will help you to choose the VEGF inhibitor that is the best choice for you. Axitinib, cabozantinib, and lenvatinib are medicines that are used frequently in combination with an immunotherapy. Lenvatinib can be used with a medicine called everolimus, which is an mTOR inhibitor. I realize that this is a lot of information, but remember, you and your doctor will work together to pick the best treatment for you. How are VEGF inhibitors different from each other? Some VEGF inhibitors are more narrowly targeted to VEGF, and some are more broadly targeted and affect other receptors too. Targeting more receptors can theoretically be a positive thing, since these other targets can also help to shrink the tumor, but it can also be a downside, since affecting more targets can potentially increase toxicity. Some VEGF inhibitors stay in the body for a longer time, and some stay in the body for a shorter time. VEGF inhibitors that stay in the body longer may only need to be taken once a day, but can take longer to leave the system if you're having toxicity and need to stop. How effective are VEGF inhibitors? When given in combination with immunotherapy, approximately 55 to 70% of patients see their tumors shrink on imaging. A subset of this 55 to 70%, about 8 to 16% of patients, see their tumors completely respond to therapy on imaging. This therapy is often used in the first-line setting. When should a patient receive a VEGF inhibitor instead of immunotherapy, or vice versa? Well, for example, your doctor might prefer to give you a VEGF inhibitor if you have a history of significant autoimmune disease that makes an immunotherapy treatment too dangerous. I do want to mention that you might sometimes still be able to receive an immunotherapy if you have a history of autoimmune disease if you and your doctor decide that the benefits outweigh the risks. Your doctor may prefer to give you an immunotherapy instead of a VEGF inhibitor if you have a history of hard-to-control blood pressure, for example. It is important to know, however, that most patients will receive both types of treatments over time. For example, immunotherapy is often given in combination with a VEGF inhibitor, and immunotherapies can often be given after VEGF inhibitors have stopped working. So really, most patients will end up receiving both treatments over time. How are VEGF inhibitors given? VEGF inhibitors are given as a pill that you will take at home, usually once or twice a day. Try to take the medicine around the same time every day. Your doctor will give you more specific instructions on how to take the medication that you are prescribed. For example, whether it should be taken with or without food. VEGF inhibitors can cause a number of different toxicities. Many of these are due to the effects of these inhibitors on blood vessel growth and dilation throughout the body. Sometimes serious side effects can occur. Therefore, it is important to let your doctor know about problems that you're having early on. Some patients may receive a VEGF inhibitor alone in the first-line setting if they cannot receive immunotherapy, if their doctor does not think that they need to receive combination therapy, or if they have a type of kidney cancer other than clear cell kidney cancer. Combination therapies are less well studied in patients with non-clear cell kidney cancer. VEGF inhibitors are often used alone in second and later line settings. These medicines can be effective in this setting as well, but response rates are sometimes lower, often around 20%. Some possible side effects include, but are not limited to, high blood pressure, a rash on the hands and feet, diarrhea, liver inflammation, protein in the urine, and in rare cases, people have gotten very sick or died from the side effects of these medicines. Make sure to ask your doctor about the full list of possible side effects. You can also go through the FDA package insert with them. This insert contains all of the significant warnings that the FDA thinks are important for patients and their doctors to know. We will be talking about a number of different side effects that can happen when you take a VEGF inhibitor. This does not mean that you will have a particular side effect. I think that is important for patients and families to be aware of the possible side effects that can happen, so that you can know what to watch out for and also how these side effects might be managed. In this way, I think that patients can have the best possible chance of benefiting from these important medicines. How can patients take these medicines safely? Always take the medicine for the instructions given to you by your doctor. If you're having side effects, let your medical team know. If you're having a very severe side effect and you can't get in touch with your doctor quickly, you may need to go to the emergency department. In general, I believe that patients and their families know the patient the best. If something really doesn't look or feel right, let your medical team know. Fatigue can be very commonly seen when patients are taking VEGF inhibitors. In general, fatigue can be due to many different causes. One cause can be a low thyroid level. VEGF inhibitors can cause your thyroid function to be low, and your doctor can pick this up on a routine blood test. If this is found, usually your doctor will just need to start you on a thyroid replacement pill, and you will start to feel much better. Many patients with a diagnosis of cancer can become depressed, and if this is the case, we should make sure to treat depression with therapy, medicine, or sometimes both. Exercise can also be very helpful. High blood pressure is very commonly seen with VEGF inhibitors because of their effect on the blood vessels. Please make sure to check your blood pressure at least once every day, especially when you are starting a new VEGF inhibitor or increasing the dose of one. Your doctor may need to start medicines to help control your blood pressure, including amlodipine or lisinopril. If your blood pressure gets very high, for example, if the top number goes over 160 or the bottom number over 100, your doctor may ask you to stop the medicine while we get your blood pressure back under control. Also note that if you take a treatment break from a VEGF inhibitor, your blood pressure can go back down, so you may have to back off of your blood pressure medicines. In general, I would say that monitoring your blood pressure every day is one of the most important things that you can do to make sure that you stay safe while you're on these medicines. Remember that you will only be seeing your doctor every several weeks, but your blood pressure can go high in between these visits. If your blood pressure becomes elevated, you may not have any symptoms, but this high blood pressure can still be quite dangerous. Therefore, it is very important to keep a close eye on your blood pressure and let your medical team know if it is not under good control. Oftentimes, by adding a blood pressure medicine or potentially reducing the dose if needed, we can get the blood pressure back under control and keep you on these medicines safely. Diarrhea is also a common side effect that is seen with VEGF inhibitors because the bowels are very sensitive to changes in blood flow. Imodium or loperamide can help to control and manage this diarrhea, but please make sure to let your medical team know what's going on, because if you are having significant abdominal pain or fevers, for example, that could mean that there could be an infectious cause of the diarrhea as well. And we will want to make sure to rule that out and treat it if we need to. Diarrhea is more complex to manage in patients who are also on an immunotherapy. That is because both immunotherapy and a VEGF inhibitor can cause diarrhea. Oftentimes, it is quite easy to figure out what the cause is, however. We can stop the VEGF inhibitor for a few days and see if the diarrhea gets better. If the diarrhea gets better, then it was probably due to the VEGF inhibitor. If the diarrhea does not get better, then it may be due to the immunotherapy, and your doctor may need to start you on a steroid to help to treat the diarrhea. Changes in taste can also have a big impact on your quality of life and can oftentimes be seen with a VEGF inhibitor. Avoiding spicy foods can help. You can also try to use a soft toothbrush, keep your mouth clean, and occasionally use a numbing mouthwash. In some cases, you and your doctor may decide to give you a treatment break or lower the dose of the medicine if the side effects are very severe or bothersome. Some patients taking a VEGF inhibitor can develop a rash on their hands and feet. This is called hand-foot syndrome. Patients can have findings like blisters, calluses, or redness of the skin, or peeling that can be painful and occasionally can even interfere with your daily activities. Keep your skin moisturized prior to and throughout therapy. Other things that can help including wearing comfortable shoes and socks, or occasionally you may need to stop the treatment for a little while or reduce the dose to let your skin heal. If the hand-foot syndrome becomes quite severe, you may need to see a skin specialist or dermatologist to get their advice on how to treat this. Your doctor may also watch for changes in kidney function, inflammation of the liver, or low blood counts. These can be tracked in routine blood work. Therefore, it is important to see your doctor and team regularly for checkups when you are on a VEGF inhibitor. By working together, you and your doctor can make sure that you take these medicines safely and get the most possible benefit from them. In summary, VEGF inhibitors are an important part of the treatment for kidney cancer. Along with immunotherapy, It is one of the main treatments that we use. These medicines are often given with immunotherapy as a combination, but they can be given alone as well. These medicines can have a variety of different side effects, so make sure that you work with your medical team to manage these side effects aggressively and early. It is easier and safer to intervene early on the side effects. Sometimes you may need to take a break from the VEGF inhibitor or reduce the dose of the VEGF inhibitor. Please make sure to take your blood pressure every day, especially when starting a VEGF inhibitor or changing the dose. And lastly, please remember to be an active participant in your care. Your medical team wants to hear how your treatment is going so we can make sure that you are tolerating as well as possible and that we can keep the treatment safe for you.
Thank you so much for joining today. I hope that you've learned a little bit about how VEGF inhibitors can be used in the treatment of kidney cancer and how these medicines can be taken in the safest way possible. So with that, thank you again.
Hi, everyone. We've reached our first break and our panel discussion. I'm going to give the panelists the ability to unmute their microphones here. And if anyone has any questions, please feel free to type them into the chat box and we'll be happy to answer your questions. I see that Dr. O'Malley and Dr. Falzarano is here. Welcome.
Hi.
Hey, thanks for having us.
Hi, Padraic. How are you?
Hey, Sara, not too bad. How are you?
Good.
I believe we're still waiting on Dr. Ramnaraign and Dr. Chatzkel to log in.
I think while we're waiting for people to not be as shy, I would just say a few words. Just I think, I think it's important, as you see from the sort of panelists that are available today, high-end, I think, treatment centers that offer excellent kidney cancer care. You'll see there's a lot of people from different areas of expertise and a lot of different experts, and we all have different tools that we sort of use to accomplish what we do. But one of the most important things we do at University of Florida, and I think other high volume centers that have real expertise in kidney cancers, we work together a lot as a team. I think anywhere you go, particularly the more advanced type of disease you have, that's important to have that sort of team approach because it takes experts in a multitude of fields to sort of figure out the best treatment for patients. Particularly where there are so many different options these days, we are really trying to focus in on how to optimize the mix of those to sort of improve cancer control or cure, but at the same time also limit the morbidity and the toxicities of any treatment. So, I know what Dr. Ramnaraign and Dr. Chatzkel talked about, some of the sort of potential toxicities associated with these therapies. Overall, they are, in the grand scheme of things, very well tolerated. But there are ways we can mix and match these therapies, including surgery, to sort of limit that while at the same time getting excellent outcomes for patients. So I think for most patients, when they're looking at their treatment, it's important to look at places that have, good experts, not just in one area, but in multiple areas, because you're going to need a team rather than just a single provider.
I agree with what you said, Padraic, and I'm very happy to be here and be part of this team.
Yeah, I think we've done an excellent job of having a great team, and that goes a long way for patients. And it also goes a long way for the physicians as well. It's always great when you work with colleagues that you get along with and who have expertise in their areas, because there's certainly certain things we don't all know everything about kidney cancer. And if we think we did, we're probably misleading ourselves. But it's great when you've got colleagues that you can rely on and talk to frankly and openly about these sorts of things. That's what I think helps really drive patient care forward.
I'd like to thank you both for all of your hard work and research that you put into this and spending time putting together these presentations. We always reach more people with the video content. And so I know that we're going to have lots of people that are viewing this over the next few months, and your contribution to this is very much appreciated.
Absolutely.
Yeah, it's probably one of the few positives of the whole COVID pandemic is that it has made virtual sort of webinars and talks and things like this more readily available and more the norm. And I think that's actually done a good job in many ways of distributing information to patients much more broadly than it ever used to. I'd say that's one of the positives, I guess. There's not been many, but it's one. So we'll take it.
Well said.
And if there are any questions regarding the pathology report or the pathologist or anything, I mean, I think the email is available from this meeting, but also, you know, you can Google my name, and the UF website will have my email that is publicly available. So I think it's, you know, it's good to reach out. Please don't be, you know, shy. We're here to answer questions.
Hi, good morning, everybody. My name is Abdullah Malkawi. I'm one of the abdominal imaging specialists in the radiology department in the University of Florida in Gainesville. I would like to give you somewhat of an introduction into imaging and what we do here in the radiology department for patients with kidney and bladder disease and patients with cancer. We're gonna go right ahead and start with this hopefully short and informative presentation. So we're gonna hopefully talk about some of the role of imaging in kidney and bladder disease, and we're gonna jump right in. We're gonna talk about the role of diagnostic imaging. We're gonna see where the kidneys are, how do we see them, how do we look for cancer, and you know what modality is the best. You know, there's always, everybody gets different imaging every once in a while. You know, which one is the best, how do they differ from each other, and what else do we do here in the radiology department, and what is the role of interventional radiology. I'm going to talk a little bit about kidney and bladder cancer, but I'm going to leave most of this information to my colleagues who are better equipped to talk about them. But just a couple of points. Kidney cancer is very common, kidney and bladder cancer, and they're both usually within the top 10 diagnosed cancers in the United States. They have many signs and symptoms, and patients present with different signs and symptoms depending on where the location of their cancer, the size, and its effect on the body. It can range anywhere from blood in their urine all the way to something that you could feel with your hands. And sometimes there are not so obvious signs, like just feeling tired and fatigued and loss of appetite and sometimes weight loss. But then when we suspect kidney cancer, then there are lots of tests that we could do. And we start off usually with getting a proper history and physical examination. We could do blood tests, urine analysis, and the role that we're going to talk about today here is imaging. And this is our old-timer doctor who is trying to, you know, find where the abdominal organs is based on drawings and doing some mathematical equations on this patient's abdomen, long time ago. But so what do we do in terms of imaging? What is the role of imaging in cancer, specifically in kidney cancer? Well, first of all, we could look at the suspicious areas that might be cancer. And, you know, a lot of times you get a CAT scan done or an ultrasound, and we see things in the kidneys that we don't know what they are. So we can do more imaging to kind of define what these things are. Could they be cancer? Are they benign? So imaging is very helpful in that sense, in saying whether things look benign or they look malignant. If the patient has cancer, then imaging will tell us how far it's spread. And that's an important part in staging the disease and, you know, figuring out, you know, what the treatment is in those situations. And then sometimes if you get the treatment, if you get like different types of treatment, whether a pharmaceutical or a surgical, then we can help with imaging, say, well, is the treatment working? Is the cancer going away? Is it getting worse? And, you know, the final part is we could actually look at signs to see if the cancer is coming back after treatment and after remission. So that's really what we're going to do here with imaging. Oh, looks like same guy is back again. So before the era of imaging, the only way to see the kidneys was to go looking for them, meaning you had to open up the abdomen. You had to actually go into surgery, look at the organs to actually see if they have any disease or not. But that's been a long time ago, because we've started to have good radiological imaging about 50 years ago. We started to have imaging that we could look at organs inside the abdomen. So what is imaging? Imaging basically getting pictures of the inside of your abdomen, inside of your body as a whole, and try to define each organ on its own and try to define what looks like a mass, if it's a benign or malignant lesion. We have many ways to get pictures, and many of you are familiar with a lot of these tests and a lot of these names. But we have X-rays, we have ultrasound, we have CT or CAT scans, we have MRI, and we have other modalities like nuclear medicine scans, like PET CTs and bone scans and renal scans, etc. Each one of these has its advantage and disadvantage in terms of looking at the kidneys and the bladder. But we're going to speak mainly about ultrasound, CT, and MRI, and a little bit about PET CT. One thing to know about X-rays is X-rays are not specifically used to look at kidneys, but they're used to look at, sometimes the chest or sometimes the abdomen in a more general evaluation way. So we're going to skip those right now because we don't use them anymore often to look at the kidneys. So we're going to go ahead and start with, where are the kidneys? Now, the kidneys are peculiar organs. Although they are inside the abdominal cavity, they're actually more towards the back of the abdominal cavity. They're right in front of your ribs. If you feel the backbone or the spine, as we call it, and these ribs, they're right in front of it. This is the last rib, and the kidneys are in front of it. This is more of a magnified picture that kind of shows where the kidneys are. They're right in front of the bone. So they're actually behind your bowel, behind the stomach, behind the liver. These organs are way in the back, and that makes them a little bit different in terms of if they do have cancer or any form of disease of the kidneys and any form of imaging, you need to make sure that you get a good look at them and you know exactly where they are. And that also kind of translates into symptoms, because sometimes patients with kidney disease present with back pain. And like I said, back pain could be many times, attributed to muscle or bone or discs or other organs, but kidney is definitely one of them. And if anybody's had a stone before, that the pain is a little bit different, starts in the side, maybe hits your back, but it's really because where the kidneys are, which is very, very interesting. This is another kind of overview of the kidneys. Here we see the organs, the proper organs of the kidneys, and we see coming off of them what we call the ureters, or the passageway for urine coming from the kidneys to be stored temporarily in the urinary bladder, which is way down here in the pelvis at the lowest portion in the abdominal cavity. This is somewhat of a close-up view of the urinary bladder on the inside. It's a very thick muscular structure and has very different layers of cells that are very interesting, and each has a function. But this is the general scheme of what the kidneys and bladder look like. And that kind of goes along with their function. They get the blood supply, they filter it, and then the toxins and the urine, they get filtered out and they get sent down into the bladder, and the bladder gets rid of them afterwards. This is another kind of a diagrammatic representation of the kidney from the inside. It's from a cadaver. This is just a nice picture that shows various areas in the kidneys, and each functional unit works to perform a major function of the overall kidney physiology of what it does. And we're not going to go into this, but if we look at a diagram of where, of how cancer looks like, if this is the normal kidney, then sometimes you can have those neoplasms or masses arising from the kidney. And depending on where they grow, what they grow into, if they grow into a vein or if they go into adjacent organs, imaging can help decide that. So basically, this is what we're trying to accomplish with imaging, is to say, well, this cancer is located here, it does this, it goes there, and so on and so forth. And this will help us guide treatment. Okay, so we're going to jump right into the first modality that we use to look at the kidneys. And the first one, and this is a very, very common modality to use. This is called the ultrasound machine. And many of you have seen an ultrasound machine. It's a very popular imaging device that's available in many, many offices. It's cheap. It doesn't have any radiation effect to it. It's not invasive. Overall, it's a very good modality to look at the kidneys. It's great in evaluating, the kidneys in terms of disease. Is it blocked? If you have big masses in there. It's not very good in finding masses when they're very small. But then again, small masses tend to be, they don't tend to cause symptoms, and they're not very dangerous per se. But obviously, if we suspect kidney cancer and we don't see an ultrasound, many times we move into more advanced imaging and more specific imaging. I'm going to show you a couple of pictures here from an ultrasound machine. This is a normal kidney that I actually had this patient last week. Very normal looking kidney. You see, it really looks like the diagram that we're looking at. It looks like a bean, right? This is a bean-shaped organ. That's how they describe it. Very normal kidney. This is another patient that we had last month on ultrasound, and you could see here this ball, right? There's this dark ball coming off the edge of the kidney, and this is how ultrasound shows its images. It's like salt and pepper, really bright spots and dark spots. And when we see these masses or balls arising from an organ, then that's when we get a light bulb turned on and we suspect cancer. So that's ultrasound. We're going to go a little bit into CT. And CT really, this is a CT machine. They all look somewhat the same. You lay on the table, you go inside, and you get scanned very quickly. Like the whole scan takes less than a minute many times. And even if you get multiple scans, or what we call multiple phases, when we give IV dye or contrast, the whole scan is usually less than 10 minutes in most situations. So it's very fast. Usually they're done within 2 to 7 minutes, these scans. It's available almost everywhere. In the past 20 years, CT has really become the mainstay of radiology, where wherever you go, any hospital that you go to, and many imaging centers, they almost always have CAT scans available. It's faster and a little bit more affordable than MRI, but it's still more expensive than ultrasound. It does use X-rays, so there is that element of radiation, but it's minimal radiation, where when you talk about radiation with CT or X-ray, you're usually talking about low doses that are comparable to your lifetime exposure of radiation just from being out there in the world and the sun. And I'll talk a little bit more about IV contrast, because there are usually questions about IV contrast, but the gist of contrast is that it really helps us see masses and organs much, much better than without it. And I'll show you some examples of a CAT scan. This is a CAT scan with IV contrast, and you could see here, this is what we call a cross-sectional picture that's taken from the abdomen. And these are your kidneys right there, and you see them better here on this picture in a longitudinal view. You can see the kidneys here, very nice. They look very normal. And we see them this bright and this nice because of the IV contrast. And that's why it's important. that we try to use it, when we need it. And I'll show you an example of a kidney cancer in the left kidney in one of our patients. Again, this patient did receive IV contrast, and this is that ball that we saw something similar to it on ultrasound, but this is on CT. This is how it looks like. And IV contrast really helps us say, well, this is exactly the margin of the tumor. And we could say, well, this tumor does invade or does not invade, or extends into an organ or doesn't extend. So CT really helps us, especially with contrast, to find those lesions and detect their extension and see how bad they are, the exact size that we're dealing with. So this is an example of a kidney cancer on CT. This is an example of a bladder cancer on CT. So this is where way down in the pelvic area, in the lower abdomen. This is your urinary bladder here, this big ball of fluid that's holding a lot of urine. And at the edge of it is this abnormal kind of maybe triangular shaped mass that's arising from the wall of the bladder. And this is an example of bladder cancer that we see on CT. So let me talk a little bit about IV contrast and dye, and I can hopefully answer some of your questions. And if anybody has more questions later, I'm happy to. IV contrast basically is a solution that contains a form of iodine, and it's a non-binding iodine, which means that the iodine flows freely in the bloodstream, and that gets filtered by the kidney and then gets excreted in the urine. It helps us see tissues better because it goes anywhere that blood goes. So we could see things, let's say, if a tumor, for example, drinks up more blood than the adjacent organs, then it's going to show up brighter and better. So this is really the advantage of IV contrast. It helps us define organs better, helps us define masses better, and it's very useful. We use IV contrast for CT and for MRI. With CT, it has iodine. With MRI, it has another substance called gadolinium. It's like an earth-based magnet. Again, both of these are not harmful to the body, and they get excreted by the kidneys and by the liver. So that's their advantage, and we, whenever we need them, we tend to use them very frequently because of that advantage. Now, there are precautions, of course. Solutions, they come with some form of preservative that helps keep the iodine or the gadolinium there. And some people have allergic reactions. We call them allergic-like reactions because they're weird. They don't really follow the same pattern of allergies like your regular hay fever, for example. So we call them allergic-like reactions. They're not common, they're less than 1% of the population. And sometimes even when you have these allergic-like reactions, we could give you a medication to help reduce the symptoms that show up when you get IV contrast if you need it. And these allergic reactions, they can range from a simple skin rash, but sometimes they could actually be life-threatening complications. And if someone has that or tends to have a more serious complication from getting IV contrast, then we usually don't give them IV contrast anymore unless it's an emergency and we think that we could deal with it. Rarely also, there's another issue with IV contrast, and rarely it can affect the kidney function. So in another word, if your kidney function is already poor, if it's already bad, then getting IV contrast may make it a little bit worse. Now, this is still a phenomenon that's being studied and researched, but we now are fairly confident that the IV contrast doesn't have much effect on the kidneys. And if it does, it's rare. And it usually happens with patients who already have a poor kidney function. Having said that, again, if the IV contrast is going to help us determine, whether cancer has spread or not, then we just have to weigh the benefit versus risk. What's the risk of getting, your kidney function getting a little bit worse versus finding out if you have cancer metastases? Then we have to always ask that question and see if there are any other alternatives that could answer the question without affecting the kidney. But I hope I gave you a little bit of insight about the IV contrast, but I'm happy to answer more questions. Jumping into MRI. So MRI, or magnetic resonance imaging, it's a very advanced technology that was developed in the 90s, and it doesn't have radiation. It kind of relies on the magnetic properties of water and tissue. It's very high tech. It's very interesting how it works. And many people consider this, the best imaging machine overall for organs. But in reality, it's really hard to apply MRI on everybody, and everybody gets an MRI because everybody has a different needs, and not everybody can tolerate, getting an MRI scan, especially that these things, these things take a longer time to scan. A typical MRI scan ranges between 15 and 30 minutes, sometimes longer. And you have to be able to kind of hold still for a long time and hold your breath for a long time. But when it works, it is excellent. Yes. It's at least comparable to CT and a little better, when it works fine. And when it does, like I said, it produces excellent images, and we could find many things with MRI, especially if they're smaller masses and smaller lesions. So we love MRI. We love to use it, but we just have to understand the limitations, that it's a little bit more expensive than CT. Maybe more than a little bit, but more expensive than CT, and it just takes a longer time to image, and not everybody can tolerate it. These are some pictures from an MRI for a patient with kidney cancer that we recently had here undergoing treatment. And this patient unfortunately had this big tumor arising from his kidney on this left side, and we see it on different MRI sequences. We call them sequences because they're different than CT, and each sequence produces a different image quality and different type of picture. Think of it as filters, on your camera phone. You could get black and white filters, you could get extra color, less color, and similar things with MRI. The acquisition, the way the machine gets the images are different. Moving on, we're going to talk a little bit about one of the more popular nuclear medicine scans that we do. This is a machine that's called a PET scan, or PET CT. It uses both modalities. It uses the CAT scan that we saw, and uses something called PET, or this is short for positron emission tomography. Basically, what we do with these is that we inject the patient with a radioactive substance, usually glucose. We tag these special glucose cells with an active radio tracer, something that emits a nuclear rays, like gamma rays, and those that we could detect by this machine that's called the PET scan. This usually gives us a very good idea about tumors and where they have spread, because this machine is actually looking at areas that drink a lot of glucose, and things that consume a lot of glucose are suspicious for cancer. Now, again, like every other modality, like every other imaging modality, not everybody may benefit from a tumor, because, believe it or not, some cancers are slow growing, and those slow growing cancers, and they're very popular in the kidney cancer population, they don't always drink or eat up a lot of contrast. They're usually, sometimes some of them are, they're lazy tumors. They grow, but they grow slow. They might grow, half an inch every year. They might grow, a couple of inches a year. So they're not really consuming that much glucose. So not all of them are going to show up as these bright red lesions on PET scan. And this is an example of an active, highly active cancer in the left kidney that we could see on the PET scan. Okay. What else? So what else can we do? So we talked about the diagnostic role of imaging. So we talked about ultrasound, CT, MRI, and PET scan. All of these modalities help us find where if there is any cancer, or say, well, this thing in the kidney here is benign or malignant, or in the bladder is it benign or malignant. It can help us tell if it's spread or not, and it can help us stage the disease. So we can say, well, this tumor invades another organ, or is very small and you could take it out, or it's spread into all over, into different places. So that's the role of what we call diagnostic imaging. So we're diagnosing cancers, and we're diagnosing, their stage of disease, or if they responded to treatment. What else can we do? So in the radiology world, the radiologists also help do either more diagnostic tests or more treatment therapeutic tests. So we're going to talk about CT, or ultrasound guided biopsies, where we get a biopsy, we get tissue samples from masses. We're going to talk a little bit about ablations, and it's a form of treatment for kidney cancers. And we're going to mention a little bit angiographic embolization. And I'll just briefly mention those. So I'm going to show you here a picture. This is a CAT scan of a patient of ours who had a tumor in his left kidney, and we see it here, and we see it here. And in order to find out exactly what type of tumor this is, we took this patient to the CAT scan suite, and we put a needle into the tumor using the CT itself. So we can scan the patient, find where the tumor is, and then we can use the CAT scan to help us guide the needle exactly where it needs to be and avoid injury to other organs, put the needle where it needs to be, and get tissue from the organ. And this will give us a very good idea of what type of tumor that we're dealing with, what type of genetic or DNA mutations there is in it, and what type of therapy might work best for these type of tumors. So that's one other thing that the radiologist can help with, is getting tissue samples, minimally invasive. You only need some sedation and local anesthesia, and you're in and out in less than an hour, and you have very good answers and very good guidance to your further treatment. This is an example of a patient who we know he has kidney cancer because we biopsied it before. And this patient, for a reason or another, the best treatment option for them was to get something called an ablation. And this is another form of a minimally invasive treatment or therapy for these cancers, where the patient, for a reason or another, for example, they can't get surgery, or they can't get medical treatment for these. And we elect that this patient might benefit from these ablation techniques. Same thing like the biopsy. We use the CT machine to guide us, put these probes inside the mass. And this is a very interesting example and modality, treatment modality that was developed in the last 15 years. It's called cryoablation. And cryoablation inside the body has been relatively recently developed. We put these probes in, and then we freeze the tumor. We freeze them. And there's an ice ball that we can actually see developing around the kidney. And this not only kills the tumor and what's around the tumor, it also helps the body fight it with its immune response, because it exposes the tumor to the immune cells and tells the body, hey, this is something foreign, you need to attack it. So it helps the body both ways in killing the tumor and letting the body know this is the tumor that you need to attack. So this is another example of the way we could treat things and help, the radiologist can help in treating those lesions. Embolization, I'm not going to show you an example of that, but every once in a while you have patients, unfortunately, with large tumors that may bleed so much, and the interventional radiologist will go in and kind of knock out some of these arteries that are supplying these tumors, and help the surgeon in doing those operations and minimize the risk of bleeding. Okay. So what imaging modality or what type of treatment is best for you? each patient is different. So every treatment pathway is like they say, it's kind of customized for your needs. So it's really what works for you in your situation. You just need to talk to your doctor, talk with the radiologist and find what the best way for you to get the best available exam and the best available treatment modality. Thank you very much. I hope this was a little bit informative, and I'm happy to answer any questions afterwards. So this is just with the rising costs of healthcare and everybody's getting busy in this hospital, they're trying to put two people at the same time in the MRI, which unfortunately doesn't work. Again, thank you very much for listening. And if you have any questions afterwards, I'm happy to help. Thank you and have a nice day.
Welcome and thank you for all who are attending. My name is Paul Crispen, and I'm a urologist that works at the UF Health Cancer Center, and I specialize in treating urologic cancers, including kidney cancer. Before I get started talking about surgical considerations when evaluating and treating patients for kidney cancer, I'd like to give a huge thank you to the Judy Nicholson Kidney Cancer Foundation for making this possible and everything that they do for patients afflicted with kidney cancer, their families, and their loved ones. So when we think about kidney cancer and surgical indications, like any other cancer, it's important to consider the stage of cancer. Now, I'm not going to go into the exact staging of kidney cancer because we're going to have one of our experts, Dr. Delaune, go over that in the next presentation. But I will start by saying that surgery plays a major role in the first three stages of kidney cancer, where it's really the predominant therapy. And within stage 1 kidney cancer, in addition to surgical removal of the tumor, we also have the potential to use thermal ablation. Now, the role of surgery in stage 4 disease is still under development, and I would say is a matter of debate and under current study based upon advancements in the field of treatments that we have systemically for patients with stage 4 disease. And we'll go into a little bit of why that is later on in the presentation as well. So when we look at surgical techniques available to treat these renal tumors, we can really group those into two buckets. And again, that would be thermal ablation and nephrectomy. Thermal ablation can involve either cooling the tumor to very low temperatures to kill it or heating it up. Cryotherapy is demonstrated in this upper panel where you see 3 probes that have been placed into the tumor in the kidney, and that high pressure argon gas is being pumped into these probes to lower the temperature down to minus 40 degrees Celsius in order to freeze the tumor and kill it. Opposed to this would be radiofrequency ablation, in which we heat the tumor to very high temperatures to eliminate the tumor from the kidney. Now, when we perform these procedures at our center, it's typically done by an interventional radiologist who does them percutaneously under CT guidance. And having used that technique, we see most patients going home the same day and making a full recovery, usually in 1 to 2 days. However, a major limitation of thermal ablation for patients with kidney cancer is the size of the tumor that can be treated effectively. This treatment is really best for patients where the tumor is in a favorable location and is less than 3 centimeters in size. The standard surgical technique for addressing kidney tumors remains nephrectomy, whether it be partial nephrectomy or total nephrectomy. On this bottom panel, you'll see a small tumor in the lower pole of the kidney here. And the tumor has now been removed. It's been cut away, leaving only normal tissue behind. And then the remnant kidney has been sutured closed by the surgeon. Now, this partial nephrectomy can either be done by the standard open approach or robotically with laparoscopic assistance. The other option for larger and more complex tumors would be a total nephrectomy, which would be accomplished via an open approach or a laparoscopic approach in surgeons who are comfortable with that technique. One of the biggest advancements in my mind over the past 10 years has been the use of robotic partial nephrectomies. There are multiple benefits of using this technique, including use of smaller incisions a faster recovery, shorter hospital stay, and in some series would suggest decreased complications. Now, the rate of decreased complications associated with robotic surgery is controversial, and some will say is likely related to those patients not having very complex tumors, and it's a matter of selection bias. In this top panel here, you'll see a robotic approach being employed. This is the patient that is prepped and draped in the operating room, and they have 4 robotic trocars that are in place where we can pass robotic instruments and cameras to remove the tumor. The bottom panel is the surgeon's view when he's sitting at the robotic console, and here you can see the working instruments, including a pair of forceps and some surgical scissors. In this picture, you see the tumor in the kidney here, and this margin of resection, which the surgeon has outlined with cautery. So the next step in this surgery will be cutting the tumor free, and then these instruments will be exchanged for needle drivers to sew the defect in the kidney closed. Open approaches for partial nephrectomy are still very common. I probably use open approaches in half the patients I treat with these tumors. The way I decide on when I'm going to use an open approach or robotic approach is dependent upon several factors, including the complexity, size of the tumor, the location of the tumor within the kidney, and if the kidney, if the patient's going to benefit from having the kidney cooled during surgery to help preserve renal function. Also, patients may benefit from this open approach if they have multiple tumors throughout the kidney, and some patients may not be able to undergo a minimally invasive approach due to having multiple adhesions from prior abdominal surgeries. When looking at a total nephrectomy, which has been classically referred to as a radical nephrectomy, we typically employ this technique when the tumors are larger for stage 2 tumors, which are defined as being 7 centimeters or greater. Those that are complex, which may be involving surrounding structures, such as the bowels, the diaphragm, the abdominal sidewall, or invasion of the tumor directly into the renal veins or inferior vena cava. And looking at this panel on the right, you can see, unfortunately, this patient has had tumors discovered on both sides. On the right side, this is a smaller tumor, and then for this patient, I recommended a partial nephrectomy on the right side, but then for his left-sided large renal mass, I could not offer him a partial nephrectomy due to complexity. So after his right-sided partial nephrectomy, then several weeks later, we took him for removal of the larger left-sided mass. Now, one thing that patients will often ask me about is during their surgery and removal of the renal tumor, if we will perform a lymph node dissection, and they will often ask if their adrenal gland has to be removed during the time of surgery. Now, when we look at the initial description of a radical nephrectomy, and this was made by Dr. Robson from the University of Toronto back in 1969, the initial supported surgery included removal of the kidney, of course, all of the fat surrounding the kidney, the adrenal gland located on the same side as the kidney, and the regional lymph nodes. And in his initial series of over 80 patients, he found that the lymph nodes were involved in 22% of the time. However, the adrenal gland was only involved in about 6% of the time. He still recommended routine removal. But when we look at contemporary radical nephrectomies or contemporary total nephrectomies, we only notice the adrenal gland to be involved in about 1 to 2% of the time. And typically, we can tell if the adrenal gland is involved based upon their preoperative CT scan or MRI. And so we'll know this going into the surgery if we think we have to remove an adrenal gland. Also, one thing we've learned over time is that after surgery, patients will have an equal chance of developing the cancer in the adrenal gland on the same side as the tumor and on the opposite side. And so you may put the patient in a bad position if you always go ahead and remove a normal appearing adrenal gland from that same side. And lastly, no study has shown a benefit of removing the adrenal gland and improving outcomes over time. So with all of these findings, current practice does not require removal of the adrenal gland from the same side if it's radiographically normal on the preoperative imaging. And this kind of goes against the initial description by Dr. Robson in 1969. Now, in regard to lymph node dissection. We'll get to that in a moment. But this is, I think, a good example of why we don't take the adrenal glands out. This is the patient that I've treated during the last couple of years. And as you can see on the left panel, this patient has a large right-sided renal mass where the tumor has grown into the vena cava. So this is at least stage 3 disease. And over here on this panel on the right side, you see a completely normal appearing adrenal gland. So during his surgery, we went in, we removed the mass, we removed the kidney, we opened the vena cava, removed the tumor thrombus from the vena cava, but I left the normal appearing right adrenal gland in place. Thankfully, the patient had a good recovery, but when he came back to see us 6 months later, he had this scan, which showed a completely normal appearing right adrenal gland, but unfortunately, he developed a tumor, a recurrence on the opposite side. And so if I had removed this patient's normal right adrenal gland at his initial surgery, he would have been in a very bad position to have this left-sided adrenal gland removed and treated in the future, as it would have put him in a position to require the use of adrenal replacement time for the rest of his life. Now, for the use of lymph node dissections, these are routinely not performed based upon the results of randomized trials. Now, when we talk about this, I'm referring to patients with lymph nodes that appear normal on CT scans. I'm not talking about patients where the lymph nodes appear to be enlarged on their preoperative imaging. Now, on this panel on the right side, this is a patient with a large-sided left-sided tumor and also very enlarged lymph nodes between the kidney and the aorta, as can be seen here. So for this patient, we would absolutely recommend going in, removing the tumor, removing the kidney, and performing a lymph node dissection. However, for patients with normal appearing lymph nodes prior to surgery, there has been no survival benefit seen in randomized clinical trials if we go in there and perform a lymph node dissection on those patients. And actually, what they did notice was that the complication rate was higher with surgery in those patients undergoing a routine lymph node dissection, with an increased risk of bleeding from 6.5% to 9.5%, and those patients having double the risk of embolic events, such as pulmonary embolism or deep vein thrombosis. So with this, again, opposed to that initial description by Robson back in 1969, we do not routinely perform lymph node dissections in all patients unless those lymph nodes are radiographically enlarged on their preoperative imaging. Now looking at the role for removal of the kidney in patients presenting with metastatic or stage 4 kidney cancer, certainly this was routine during the cytokine era 20 to 30 years ago, when they were commonly using IL-2 and interferon alpha. And that was well supported by trials that showed, in retrospective data that showed, that patients can have an improved life expectancy by up to 12 months if the kidney is removed prior to starting their therapy. Thankfully, we have had several advances since that time in systemic therapies offered to these patients. One of the first being the introduction of VEGF inhibitors or targeted therapy back in the early 2000s. The Carmina trial evaluated the potential benefit of removing the kidney as opposed to just using medical therapy alone. And in this trial, patients either received sunitinib alone or had the kidney removed and were then started on sunitinib. And this is the survival curve from this trial that was published in the New England Journal of Medicine in 2018. And you can see here the blue line represents patients who underwent removal of the kidney and then were started on sunitinib, versus the red line, which patients just received the sunitinib alone. And in this trial, they showed that the patients who had the nephrectomy did not do any better, and if anything, did a little worse compared to patients who received the medication alone. And so this was a big change in the way that we manage these patients. Thankfully, since this time, we had another advance, and now we see improved outcomes in patients with metastatic kidney cancer that receive immunotherapy. Unfortunately, we have not had trials completed to date that really evaluate the benefit of nephrectomy in these patients. So right now at our center, we're taking this as a case-by-case basis to see if we think that patients are going to benefit from having the kidney removed prior to starting their immunotherapy or combination therapy. Now, when we look at the complications of surgery for kidney cancer, as with all abdominal surgeries, patients have the risk of bleeding, infection, injury to adjacent organs, which should be low, less than 5%, and wound complications. However, unique to nephrectomy, patients will have decreased urinary function, renal function. And this is a common question and a smart question that patients will ask is, what is their risk of needing dialysis following their nephrectomy? Also, in particular for partial nephrectomies, we have the risk of a potential urine leak from the renal remnant or bleeding in the form of a pseudoaneurysm. And lastly, you can have lymphatic leaks in patients undergoing lymph node dissections. So this is a patient that I treated several years ago. And on the panel on the left, you'll see a 5-centimeter tumor, which if you look carefully here, this very bright spot is the collecting system where the urine goes in before it transitions down into the ureter, into the bladder. So it was very close to that collecting system as we removed this tumor. And it was I would say it was a difficult partial nephrectomy. And unfortunately, following surgery, the patient both developed a urine leak and a pseudoaneurysm that required treatment. The urine leak was treated by placing a ureteral stent, which remained in place for about 6 weeks as the kidney healed. And the pseudoaneurysm or bleeding from the kidney was handled by our interventional radiology colleagues who performed a selective embolization to stop the bleeding from the kidney. So we were able to keep this kidney in place and still had a good functional outcome from the kidney, but we did have increased complications from leaving that kidney in place and trying to preserve as much renal function as possible. And so with that, you may ask, so why not just take the whole kidney out and avoid those complications altogether? Well, the main reasons why we don't advocate removing the entire kidney when possible is for 2 reasons. One reason is that we obtain the same oncologic outcomes. We obtain the same cancer survival as if we can perform a partial nephrectomy or a total nephrectomy. And so that doesn't change. We still obtain great control of the cancer. And by performing a partial nephrectomy, we aim to preserve as much renal function as possible. And that's demonstrated here nicely. And this is one of several studies that have demonstrated this. On the panel on the left and on the right, patients undergoing a total nephrectomy or radical nephrectomy are in blue, and those undergoing a partial nephrectomy are in red. And as you can see here, with 10 years of follow-up, about 12% of patients undergoing a radical nephrectomy had stage 4 renal insufficiency, as compared to only about 4 to 5% who underwent a partial nephrectomy. And then when you look, even what's more striking is patients having a decline in renal function where their GFR is less than 45 or puts them, in stage 3 renal insufficiency. Within 12 months of surgery, over 20% of patients have reached that stage 3 classification of renal insufficiency, while patients undergoing a partial nephrectomy, it doesn't even reach 5% 10 years out. And so those are the main determinants of why we'll take on those potential increased complications is equal cancer outcomes and preservation of renal function. Now, when we look at the risk of dialysis and how many patients will go on to true renal failure, thankfully, that's a very low number. And this is a series published out of Australia, which compared over 2,000 patients undergoing either total nephrectomy or partial nephrectomy. And as you can see here, the number of cases per 1,000 patient years is very low. Whenever you undergo a radical nephrectomy, it's about 5 cases per 1,000 patient years versus about close to 4 for patients undergoing partial nephrectomy. And so those were about equal. There was not a statistical significance when comparing those 2 populations. I do think what is important from this study is they looked at the risk factors and defined the risk factors for patients requiring dialysis following their kidney cancer surgery. And those would be for patients that are above the age of 65, male gender, and those with diabetes. And the biggest risk factor noted with a hazard ratio of 15 were patients with pre-existing renal dysfunction. So in conclusion, surgery still has a major role in the management of kidney cancer. And this is particularly true for patients with stages 1, 2, and 3 kidney cancer. Whenever possible, we like to employ minimally invasive and nephron-sparing surgeries or partial nephrectomies to help decrease treatment-related morbidity. And lastly, the current role for nephrectomy in patients with stage 4 disease is undefined and undergoing continued evaluation. And so I'd like to thank you all again for your time and attention. And again, a huge thank you to the Judy Nicholson Kidney Cancer Foundation for everything they do for our patients and their families with kidney cancer. Thank you very much.
All right, good morning. My name is Dr. Jess Delaune, and today I'm going to be discussing the diagnosis and staging of kidney cancer. I will go into some details of other aspects of kidney cancer as well. But I just want to thank you so much for joining us and giving me your attention. So this is the outline of my talk today. So I'm going to be talking about the epidemiology of kidney cancer, the risk factors that are associated with the development of kidney cancer, the signs and symptoms that may present in a patient who develops kidney cancer, then how the diagnosis is made and how we stage patients with kidney cancer. So cancers of the kidney do come in different shapes and sizes. The majority of these tumors involving the kidney are what we call primary kidney cancers, or renal cell carcinoma, as you may see. We designate this often RCC. There are obviously other types of tumors that may involve the kidney. This includes bladder type tumors or tumors that have spread from other sites in the body. So this is just the epidemiology behind kidney cancer, and this specific figure is looking at the estimated number of new cancer cases in the United States each year. So this is the projection for 2021. So as you can see in males, kidney cancer involves just under 50,000 patients per year, which compromises 5% of cancer cases in males. In females, this is a little bit less common, comprising about 27,000 patients each year. So what this comes out to be is that men are actually twice as likely to be diagnosed with kidney cancer compared to women. In terms of probability, this translates into about 1 in 46 males developing kidney cancer over their lifetime, and 1 in 80 females developing kidney cancer over their lifetime. Overall, this equates to being just under 600,000 people living with kidney cancer in the United States. So in terms of the estimated cancer deaths each year from kidney cancer, again, this is the estimates for 2021. You can see that kidney cancer is not on either of the top 10 lists here for males and females, with the most common overall being lung cancer, the second in males being prostate, the third in females being breast cancer, and then the third most common being colorectal cancer in both males and females. So kidney cancer actually accounts for just 2.3% of all cancer deaths per year, which is about 14,000 patients per year, including both males and females. So in terms of trends over time, what we've seen in terms of kidney cancers, starting back in the mid-1970s, so looking at the rate of new cases, you can see that this has generally increased over time, with maybe a plateau over the past decade or so. We'll have to wait to see more about that. In terms of the death rate from kidney cancer, you can see that this has stayed fairly consistent, with a possible slow downtrend over the past couple decades. So this figure is looking at the 5-year survival of patients who have been diagnosed with kidney cancer. So essentially, from the time of diagnosis, looking at 5 years, what percentage of these patients are still alive? And you can see that over time, again, since the mid-1970s, that this has consistently increased. So more patients are alive at 5 years compared to several decades ago. This is, again, due to better treatment that we've developed and better surgical techniques. So the risk factors associated with kidney cancer, predominantly we think of smoking, tobacco use, and obesity. There are other risk factors, including high blood pressure, chronic kidney problems, including patients who are on dialysis who develop multiple cysts in their kidneys as a result of being on dialysis. So hereditary conditions make up about 2% of patients with kidney cancer, and we'll talk about more about those in just 1 second. There are some toxic compounds that have been associated with the development of kidney cancer, namely asbestos and some petroleum byproducts. Sickle cell trait is a blood disorder that can be associated with a specific type of kidney cancer. And then kidney stones have been known to increase the risk of kidney cancer. So here's a list of some hereditary conditions that are associated with development of kidney cancer. And I won't go into a lot of deep detail. I just wanted to name a few of them. And these include von Hippel-Lindau syndrome, hereditary leiomyomatosis and renal cell carcinoma, hereditary papillary renal cancer, hereditary paraganglioma and pheochromocytoma, Birt-Hogg-Dubé syndrome, and tuberous sclerosis. You might ask, I've been diagnosed with kidney cancer, should I undergo genetic testing to determine if this was due to a hereditary condition? And we do have some guidelines that help us answer this question. And those include patients who are diagnosed with kidney cancer at 46 years of age or younger should undergo testing. Patients who develop multiple kidney cancers and kidney cancers in both kidneys should undergo testing. Patients who have one or more first or second degree relatives with kidney cancer should undergo testing. And then there are specific types of rare kidney cancer for which this is recommended as well. So, you might ask, how might I find out if I have kidney? What symptoms might I experience that would make me concerned? Well, traditionally, there are 3 symptoms that we often associate with kidney cancer, and that being blood in the urine, a belly pain or pain in the side, or a mass in the belly. Now, although this is kind of what we think as the classic symptoms associated with kidney cancer, this only actually occurs in about 10% of patients. So patients can otherwise present with a wide range of symptoms. These include fever, weight loss, anemia or a low red blood cell count, fatigue. And there are patients who actually develop no symptoms related to their kidney cancer. And it's discovered because a patient undergoes a scan, a CT scan, an MRI for another reason, and they find something abnormal on the kidneys. So when evaluating for kidney cancer, there are different types of imaging techniques that we can use to do that. There is an ultrasound, a computed tomography or CT scan, magnetic resonance imaging or MRI, and a positron emission tomography or PET scan. So a CT scan is generally the imaging of choice that we use to look for kidney cancer. An ultrasound may not be as accurate as a CT scan, but sometimes can differentiate between cysts and tumors. Magnetic resonance imaging or MRI may be used when we're unable to use contrast with the CT scan due to allergy or due to poor kidney function. An MRI may also be useful in looking to see if the kidney cancer has spread into the areas around the kidney, such as the blood vessels. And the PET scan may also be used at times when looking to see if the kidney cancer has spread to other parts of the body. I would direct you to another talk today that will go into this in further detail by Dr. Abdullah Malkawi, and he will talk about imaging in kidney cancer. So in terms of obtaining a diagnosis of kidney cancer, for other types of cancer, you may hear that a biopsy is how this is performed. In kidney cancer, the role for a biopsy is a little more limited. And the diagnosis of kidney cancer is actually made at the time of a removal of the kidney or removal of a part of the kidney. And the reason why surgical removal of the kidney or part of the kidney is preferred over a biopsy is because this not only will remove the concerning area out of the body, but provides us with an accurate diagnosis and stage of the kidney cancer. Other concerns with biopsy is that it is not always accurate, and some patients may undergo biopsy and it come back normal, but there still may be a kidney cancer there that we just missed. So in patients where a biopsy may be pursued is in patients where there's an area in the kidney that is suspicious for a non-kidney cancer or an infection. A biopsy may also be performed in patients who are not candidates for surgery. In some patients who have evidence that the cancer has spread to different parts of the body, a biopsy may be obtained from one of these sites. This is preferred generally because it's often easier to perform and it provides additional information. So this figure is just to describe the summary of what we just talked about and how one may diagnose the kidney cancer and the process of which that is done. So first, like I just mentioned, we obtain a CT scan. We also may obtain blood work or urine tests. And based off that is where that tells us what we need to do next. If there's an area that is very suspicious for kidney cancer, often we will proceed directly to surgical removal of the kidney. If there's evidence that the cancer has spread to other parts of the body, we will proceed to a biopsy of one of those areas, which will eventually lead us to treatment of the kidney cancer with systemic therapy options, which some of my colleagues will talk more about today. So I did just briefly want to mention that surgical removal of the kidney in patients who have spread of their kidney cancer may be considered, but this requires discussions with the surgical team and the medical oncology team. If our scans show that there is a small kidney mass, we have two options, which include just continuing to watch or surveillance with repeated CT scans or ultrasounds. The alternative being surgical removal, a part of the kidney where the mass is located, or a potentially procedure called an ablation. And prior to this, patients would undergo a biopsy prior to the ablation procedure. If based off the scans, primary kidney cancer is not suspected, this would lead us to perform a biopsy. So based off the biopsy, that will tell us the type of kidney cancer. Now, I do want to mention that there are many different types of kidney cancer, and with the most common being clear cell kidney cancer. There are several others which we group under the heading of a non-clear cell kidney cancer. For more information about this, I will refer you to Dr. Sara Falzarano's talk earlier today about the pathology port in kidney cancer. So in terms of staging, we use the TNM system. So the T stage is essentially answering the question, how big is the tumor? The N stage is answering the question, has it spread to the surrounding lymph nodes? And finally, the M stage, or metastasis stage, is answering the question, has it spread to other areas of the body? This includes the lung, the liver, the bones, and other areas. So we put these separate stages together, the T, N, and the M stage, to come up with an overall stage. So generally, you may have heard that we stage cancers from stage 1 to stage 4, with stage 1 being the earliest and stage 4 being the most advanced. So in kidney cancer, stage 1 refers to kidney cancers that are less than 7 centimeters inside and limited to the kidney itself. Stage 2 kidney cancers are similar, except they're larger than 7 centimeters, but still confined to the kidney. So stage 3 kidney cancer is when the kidney cancer has spread into the surrounding lymph nodes or into the surrounding blood vessels. Stage 4 kidney cancer is generally when kidney cancer has spread to different parts of the body, or when it's extended beyond the fibrous envelope surrounding the kidney. Now, in terms of the most common stages when we first diagnose a patient with kidney cancer, you can see that 65% of patients will actually be found to have what we call a localized kidney cancer, or a kidney cancer that's confined to the kidney itself. An additional 16% of patients will have kidney cancer that has spread to the surrounding lymph nodes when they are first diagnosed. And then a final 16%, unfortunately, will have kidney cancer that has spread to other areas of the body. In terms of how long patients may live with each of these different stages down here at the bottom, localized, regional, or distant. When kidney cancer is still confined to the kidney, you can see the majority of patients are still alive at 5 years. And even when the kidney cancer has spread to the surrounding lymph nodes, again, over 2/3 of patients are still alive at 5 years. Unfortunately, there are patients who don't make that mark. And then finally, when we find that kidney cancer has spread to other areas of the body, unfortunately, only around 14% of patients live to 5 years. Although with our new treatments, we are hoping that this percentage will continue to increase. So lastly, I did want to talk about patients who are found to have kidney cancer that has spread. All kidney cancers are not the same. Some behave more aggressively than others. And so to try to determine this, there are several different models or scores that have been developed to try to determine or to make that assessment. So what I'm showing here is what's called the IMDC prognostic model. And this is a model that walks you through these questions here on the right side, essentially asking the patient's performance status, or essentially how active is the patient. And then it asks the question, how long has it been from the time of diagnosis to the initiation of systemic treatment? And then there are several questions asking about individual lab results. And based off this score that is calculated, this gives us, this alerts us to whether the kidney cancer is considered good risk, intermediate risk, or poor risk. Generally, why this is so important is this informs which treatment we will eventually decide for each patient. And we generally group these with good risk being considered separate and intermediate risk and poor risk being grouped together. So in terms of screening for kidney cancer, I first want to say this is not recommended for the general population for the person walking down the street. But for patients who are at specific higher risk, it may be recommended. And this includes patients with those known inherited conditions that I spoke about earlier today. Also, patients who have a very strong family history of kidney cancer may be recommended to undergo screening. Young patients who are on dialysis for several years may be recommended to undergo screening. And patients who have had prior radiation to the kidney may be recommended. And this is usually done either with an ultrasound or a CT scan, depending on the scenario. I want to thank you for joining us today and spending the time listening to my talk. I hope I was able to answer some basic questions about kidney cancer. But again, thank you so much for your time.
All right. So I just requested for Dr. Malkawi and Dr. Delaune and Dr. Crispen to turn on their mics and their videos so that we can go to the panel discussion.
Yes, thank you very much again for this opportunity. It's great, wonderful organization, and glad to help prepare these presentations. Happy to answer any questions about the talk, any information that maybe not have been presented in the talk that anybody wants input on. We're happy to discuss.
Well, thank you for the kind words, Dr. Crispen. The Judy Nicholson Foundation is so thankful for all of your contributions to today's symposium. The the recording that we have today. I think it's going to serve a lot of people. And I'm sure that if there aren't any questions today, they will come up in our comments section of our social media posts in the future. So perhaps we'll reach out to you via email to get the answers to those later.
Certainly, we'd love to answer those questions at any time, whether today or in the future. We're happy to provide some contact information too, if anybody would like. That'd be wonderful.
Hi, Scott, Dr. Malkawi. Are there any questions now or?
There aren't.
Oh, okay.
I've been asking people to send them into the chat, and people have been pretty quiet today. Our first panel discussion was very similar.
Oh, looks like there's a.
Oh, there we go. We got the first one. Yep, here we go from Karen. She says, what are the prognosis for stage 3A, grade 2? And has the FDA approved Keytruda for adjuvant treatment? Any of the doctors that feel comfortable. Now, I think I see Dr. Delaune speaking, but I can't hear him.
Yeah, no, I was just looking at the question as well. So as the poster alludes to, Keytruda has recently been studied. Well, there's been a lot of drugs that have been studied after surgery in patients with, advanced kidney cancer, usually around the stage 3 setting and other high risk features. So for a long time, we know patients in this setting that unfortunately their cancer does come back at sometimes. Other patients it doesn't, but we tried over a long period of time to try to prevent it from coming back in those that do. We've tried that with different oral medications that really have not been very effective. So recently there's been a publication looking at the use of immunotherapy, which is the medication that this poster is talking about here, Keytruda, for patients who have undergone surgery for kidney cancer, given for about a year or so, and seeing if that seems to help. And so based off the recent trial, it showed that there were less in the patients who received the treatment versus patients who did not receive the treatment. There was a less chance of the cancer coming back. What we are still waiting on for the results of the trial, whether that makes any difference in terms of how long patients may live. I know intuitively that sounds like, well, yeah, if we keep it from coming back, maybe patients, well, obviously they would live longer. And unfortunately, that's not always the case. We are, because our treatments are so good for kidney cancer these days, sometimes we can start treatment if it does come back, and patients can still live a significant amount of time. And by doing it that way, we won't, because obviously some patients who have kidney cancer won't come back. And if we treat them with, the immunotherapy, it's not going to help them because it never would have come back. We just don't know who those patients are. So that's what we're still waiting on in terms of, with how beneficial it will be in the true long term. And that'll take, a couple more years of follow-up determine if that will be the case, but it's certainly really promising. I know myself, Dr. Ramnaraign, and Dr. Chatzkel you heard from today are really looking forward to the FDA's decision. I know it's been granted priority review last time I checked, so hopefully we'll have their decision soon. I suspect that it will be approved by the FDA. That is a little bit of an educated guess, but hopefully it will. This does seem to help some patients, and so we hope to be able to provide that in the near future. And I don't know, Dr. Crispen, if you had anything to add as well. I know you're on mute, but.
Let's see.
Unmute me. There we go. Hi,
Here we go.
Karen. I think that's a great question. It's one that we all would like to have answered soon by the FDA. But I think your question about the prognosis in general for a stage 3A grade 2 tumor really depends upon a lot of other factors. Will depend upon the histologic subtype of that kidney cancer, clear cell, papillary, chromophobe, or other. And there's been a lot of really good nomograms developed and risk classification systems for patients with otherwise clinically localized stage 3A tumors. One is the Leibovitz score. There's a UCLA scoring system. Sloan Kettering has developed a system for this. And they'll take into account both the grade, as you've pointed out here, the pathologic stage, such as a T3A, the size of the tumor, patient gender, presence or absence of tumor necrosis, and some other factors, and kind of give a better prediction of risk stratification for patients with T3A tumors. So it's a complex question, but there are tools out there to give you a better idea of what the chance is for that tumor coming back in the future.
Thank you, Dr. Crispen, for your elaboration on that. We've got a couple more minutes until we're scheduled to start the next panel. So if there's any other questions, please feel free to type them into the chat.
And for those that are interested, for those different nomograms, they are publicly available. It's not secret information that we only have access to. And I know this is an advocacy group, and so we want to make sure we get the information out there and available. What I'll do is in the chat, I will put the web address of a very good site for cancer nomograms that has these nomograms that I'm talking about with the kidney cancer in particular as well. So let me just pull that up here, and then I'll put it in the chat box for everybody.
Thank you very much. I'll make sure to share it on our social media page as well. Karen asks, do you find that the nomograms vary, and are they accurate?
So they do vary. And so when you look at these nomograms and you put in your individual information from one patient to another, you may have a recurrence risk that varies from less than 10% up to 40%. And so that's very challenging. And you can use these same nomograms on other patients and they'll still have significance. And so it's hard to say, when we look at individuals, it's a little bit more difficult. When we look at large groups of patients, the nomograms are a little bit more justified. But I do think that they are beneficial because a T3A 10 centimeter tumor that's high grade is going to behave differently than a 4 centimeter tumor that's low grade. And I think that's where the nomograms have the best value of giving those big blocks of space. But they are not, as in their accuracy, they are going to differ, and they're far from perfect. I think that they are, in terms of the statistics behind them, they are much better than a coin flip, though. So their accuracy is probably around 75 to 80%, depending upon the nomogram that you look at.
All right, y'all. Thank you for your time today and for contributing to this symposium. This has been great for our audience. And if you'd like to wrap anything up or say any last words, now's a good time.
Oh, no, thank you once again for the opportunity. This is tremendous efforts, and congratulations to the Judy Nicholson Kidney Cancer Foundation for putting this together. And again, I'm happy to answer any other questions. Karen, if you have feel free to reach out to me. And Scott, please feel free to share my email with any participants who want any additional contact.
I appreciate that. Thank you all.
Thank you,
we're going to hop into I'm sorry.
Yeah, thank you, everybody. Excellent opportunity. We all appreciate it. Great organization.
Thank you, Dr. Malkawi.
Hi everyone, my name is Lori Bumbaco. I'm a registered dietitian. I'm also board certified as a specialist in oncology nutrition, and I'm thrilled to be able to present to you as part of this symposium. I want to give a special thank you to Judy Nicholson Kidney Cancer Foundation for this celebration of hope and for the opportunity to promote awareness about the critical value of nutrition in kidney cancer care. So thank you so much all of you for attending. I have a lot of content to share. but only 20 minutes to get through it. So I thought it would be best if I provide you with a PowerPoint presentation. So I'm going to pull up my slides and I'm going to go through them rather quickly. So what I'm going to do is share my screen, and I look forward to sitting on the expert panel to hear some of your great questions and your feedback from my presentation. I do just want to share that the information I'm presenting is just that. It's meant to be information. So it's not meant to replace any medical advice that you might receive from your healthcare team. So these are nourishing solutions for kidney cancer. Those are my credentials there and my contact information. And on the agenda today, I'd like to review the role of nutrition, provide for you what the experts recommend for nutrition guidance, highlight specific considerations for kidney cancer, identify some of my favorite resources, and then of course we'll have opportunities for questions in that panel discussion. So maybe you're asking yourself, when and how often should I consult with an oncology dietitian? Well, the simple answer is early and often. So at the time of diagnosis, it is advised that you consult with an oncology dietitian for a unique and proactive nutrition care plan. And that's all based on your personalized and comprehensive nutrition assessment. During treatment, the role of nutrition becomes especially critical because we do know that there are some side effects that can be present because of the treatments that are used, and that nutrition care plan needs to be reassessed in order to make sure that we are maximizing and optimizing the nutrient density of your food choices. And then even in survivorship, so once treatment has concluded, and or if you are on palliative care, we do know that there is a role for nutrition care. This can help promote healing from treatments and surgery. And we do know that a nutritious diet can promote longevity as well as improving quality of life. So here are some general tips for those individuals who are diagnosed with kidney cancer. It is advised that you maintain a healthy body weight, especially lean body mass, and that is basically muscle. And this needs to be done by achieving adequate consumption of calories, protein, and micronutrients. And those requirements are different for every single individual that I work with. This may sometimes include high calorie and high protein foods and beverages, sometimes may include supplementation through the use of nutrition shakes or supplements. And as I mentioned, some of those nutrition impact symptoms, they may shift someone towards requiring modification to their plan. They may require an adjustment of texture or certain food choices in order to manage those nutrition impact symptoms, but again, optimize the nutritional quality of their diet. Now, how is nutrition impacted by kidney cancer? Well, it's pretty significant. We do know that the diagnosis can deplete nutrition status. It can create negative metabolic abnormalities, and this can all result in weight loss, but especially the loss of muscle, and if progressed, can lead to malnutrition. This is all complicated by treatment. So as I mentioned, those nutrition impact symptoms like a poor appetite or digestive issues like nausea or constipation, this may make all of that nutritional depletion even that much worse. So I do want to speak for a moment about malnutrition in cancer because it's highly prevalent. So we do see that in about up to 80% of cancer cases, those individuals at some point during their cancer care may become malnourished. And this is significant. The consequences of malnutrition are that it can reduce response to treatment, reduce quality of life, increase the side effects of treatment. It is an independent prognostic determinant. And the way I like to describe it is that malnutrition levels the playing field. So if you are an individual who has a curable cancer, if you are malnourished, this can negatively impact your outcome. And we also know that malnutrition in the setting of cachexia, which is a metabolic syndrome, this can also lead to death. So 20% of all cancer deaths occur not because of the cancer, but because of cachexia. Now there's good news. So did you know that nutrition counseling can help? It can help individuals who are diagnosed with kidney cancer. We do see that when an oncology dietitian is involved in the interdisciplinary care team, that there is an ability to retain nutrient stores as well as body weight, improve tolerance to treatment, improve surgical outcomes, and also promote healing. So it is advised from the experts that oncology dietitians conduct a nutrition assessment, which again is personalized for every single person with a cancer diagnosis. Now, I'd like to set the record straight about something. I just want to take a moment to discuss this. So the relationship between food, nutrition, and cancer, it's sort of complicated, but sometimes when you do a search online, or if you speak to a loving friend or a well-intentioned neighbor, they may give you some messages that aren't quite accurate. So perhaps you've seen something like this. If you eat this, you're going to cure your cancer. So it might be a specific food, or it might be a specific meal plan. On the opposite end of the spectrum, you might hear or read something like this. If you eat something or eat a certain type of foods, it's going to make your cancer worse, or maybe it caused your cancer in the first place. So I had to choose the dreaded villain of the moment, and that's sugar. Well, I'm here to set the record straight about that. So first and foremost, these messages, they are oversimplified. As I mentioned, the relationship between food, nutrition, and cancer, it's complicated. Just as complicated as cancer is, so is food and nutrition and the way we eat them. So it's much more involved than these oversimplified messages. I also find these types of messages to be threatening, and I think that's a shame for someone who's diagnosed. They may be already experiencing high levels of distress or anxiety, and any shame or fear or guilt about eating a certain way, that's really unfortunate, because food, I believe, should not be stressful. It should be a source of pleasure in our life. And I think that for what we understand, there is no single food that could be more harmful for us than the stress involved with deciding what to eat. And most importantly, this information is not based on evidence, and that's what I'm here to provide you with today. So maybe you're asking, what does the evidence suggest? What is a cancer protective lifestyle? Well, in a graphic, in an image, I have to share you this one. This is what the experts say. And this is from the American Institute for Cancer Research. They're part of the consortium of an international World Cancer Research Fund. And if you notice here on the bottom right corner, that any individual who has been diagnosed, they are advised to follow as many of these recommendations as they possibly can. So think of this as sort of like a checklist of things that, if you include them regularly, will support your ability to along really your cancer fighting journey. Now, what I'd like to do is just take out a handful of these recommendations, explain what the recommendation is, why it might matter, but most importantly, and the most fun for me, explain some ideas or offer some suggestions for how to apply this recommendation in practical ways. So let's start first with my favorite one. Eat a diet based on plant foods. And did you know that a plant-based diet does not mean you have to be vegan or even vegetarian? What a plant-based diet is that most of your meals and snacks contain whole grains, vegetables, fruit, beans, lentils, nuts, and seeds. Now, why do these seem to minimize risk? Well, we find that these foods are abundant in the very nutrients that support immune function, regulate inflammation, and also exert anti-cancer properties in more ways than one. So they contain antioxidants, phytochemicals, and fiber. And this way of eating also tends to be lower in calories, and this helps to support a healthy weight. Now, did you know that there are 13 different cancer types that are associated with overweight and obesity, and kidney cancer is included in that list? So how to eat a whole food plant-based diet. Another great graphic from the American Institute for Cancer Research. They call this the new American plate. And I think it's a great template for you to meal plan. So every time you're thinking about eating a meal or a snack, if you could design your plate to look like this with these proportions, you're really off and running for a plant-based diet. So hopefully what you notice is that 2/3 or more of the plate contains plant foods, whether it be whole grains from quinoa or brown rice. And then those beautiful colored vegetables I see on the plate there. And then 1/3 or less can be dedicated for your animal choices. So I see some chicken on the plate, but it could be eggs or fish. But you can also rely on some plant proteins here if you'd like. So you could replace those animal proteins with even healthier, I would say sometimes, and kidney-friendly plant proteins like beans and other legumes. The second recommendation is to eat less fast food and highly processed food. So here's a little quiz question. What percentage of calories do we eat from processed food? I didn't give you much time. It's 60%. I think that's pretty high, right? 60% of our calories come from processed foods. And these types of foods, really good examples there on the slide, are sugary drinks, cookies, crackers, chips, breakfast cereals, and deli meat. And another characteristic quality of highly processed foods are that they're highly palatable. They are full of flavor, usually from artificial sources. And this over time may increase our cravings for them and lead us to eating more and more of them. Now, why are processed foods such a concern? Why do they influence risk? Well, think about it. If 60% of the foods you're eating come from processed choices, that means maybe 40% come from those cancer protective foods in a whole food plant-based diet. So even if we just flip-flop those numbers and have 60% coming from whole food plant-based choices, we're already going to be taking a step in the right direction towards a cancer protective lifestyle. Also, these foods tend to contribute to weight gain, and as I just mentioned, that's associated with the risk for 13 different cancer types, which include kidney cancer. So how to eat less fast food and highly processed foods? I would suggest you unprocess your diet. So could you swap out some of your snack choices for whole foods that come from plants, like nuts or fresh fruit, veggies with hummus or guacamole, or even air popped popcorn? I have a great recipe for that if you ask me. Cooking at home more often, that's one easy way to minimize processed food, and then to hydrate with infused water or seltzer. The third recommendation is to eat less red meat and processed meat. Another quiz question here. What percentage of us eat processed meat every day? 63 to 74%. Did that surprise you like it did for me? It was a surprise. So the recommendations from the experts are to consume no more than 12 to 18 ounces of cooked red meat per week, and to limit processed meat, meaning if we don't need to eat it, we should probably try not to. Why do these seem to increase risk? Well, they contain what I would call a problematic package. So there are some animal fats and animal proteins, as well as sometimes the creation of carcinogens that have been associated with cancer risk. And those carcinogens include N-nitrosyl compounds, as well as these two other compounds, HCAs and PAHs. And I'm going to speak about them in a moment. So how to eat less red meat and less processed meat? Consider your habits and consider about making shifts towards happy habits. So could you replace some of your red meat with alternatives like a turkey burger or a bean burger, a vegetarian chili, or I have an individual who makes this amazing red lentil loaf. It tastes delicious. And I also think that deli sandwiches just tend to be a habit for lunch. So you could do better, I would argue. So could you make some tuna or some egg salad with hummus or even mashed avocado? It's delicious. And if you make some chicken for dinner, could you make a little extra or save some so that you can slice that into your whole wheat pita for the next day for lunch? Now, I mentioned those carcinogens. I do want to speak a moment about how to grill safely. I know we're kind of coming out of the grilling season, but sometimes some of us grill year round. So I want you to think about how you're grilling your meat. What we do know is that when we cook meat at very high temperatures, meaning like over an open flame, that this increases the concentration of cancer-causing substances that include the polycyclic aromatic hydrocarbons, as well as heterocyclic amines. So the experts want us to grill in a more safe way, and it's very easy to minimize the creation of those substances by marinating the meat. We significantly cut down on those heterocyclic amines by just simply marinating it. We can also pre-cook meat. So if you just pre-cook inside and then finish that off on the grill, you'll still get some good flavor, but again, minimizing the exposure of those carcinogens. And then trimming the fat or choosing lean cuts of meat. As soon as fat burns and drips on a grill, that smoke is what creates some carcinogens. Cutting your meat into smaller pieces, like for example, making a kebab, or going green. So thinking about grilling fruit or vegetables or the combination of them, because guess what? When we grill fruit and vegetables, it does not create those carcinogens. It's pretty interesting how nature works that way. Okay, the fourth recommendation, drink less sugary beverages. Did you know that sugary beverages are the #1 source of added sugars in our diet? So what are the recommendations? Experts really want us to minimize as much as possible those sugary drinks, including soda, juice drinks, surprise, surprise, some of those sports or electrolyte drinks. They have a lot of added sugar sometimes, as well as coffee drinks. Now, why do they increase risk? Well, there's convincing evidence that sugary beverages cause weight gain. Remember that increased risk for kidney cancer with overweight and obesity. They also lack nutrients and they're high calorie, right? So again, we could do better. We can hydrate better. And how would we do that? Well, we can create some happy habits again. So I would suggest some substitutions, replacing sugary beverages with unsweetened tea or coffee. By doing this, you're actually increasing the cancer protection of your diet because tea and coffee both contain antioxidants and polyphenols, important cancer fighters there. But also sparkling water or infused waters are great ways to have hydration without the added sugars. And the last recommendation is do not rely on dietary supplements for cancer protection. What percentage of survivors use supplements? An astonishing 80%. So chances are some of you in the audience are taking a dietary supplement or more than one. What are the recommendations? The experts simply say, don't consider a dietary supplement as necessary for cancer protection. It does not compensate for that lifestyle that I mentioned earlier. Why is this? Well, the research shows when they evaluate survivors who take supplements that there's really no benefit. Sometimes there are exceptions, and there are those individuals that require a dietary supplement, and you can discuss this with your healthcare team, but don't count on them for cancer protection. Dietary ingredients in a supplement, they don't offer the same benefit as eating the package of a whole food. And some dietary supplements may be nephrotoxic or toxic to the kidneys, or more importantly, interact with treatment. So, treatment that is used to fight the cancer, or even just over-the-counter products or other prescription medications. We see that supplements are metabolized in the same way, and they can compete and create an interaction. So how then do we not rely on dietary supplements for cancer protection? Well, I got to go back to those happy habits. So remember that plate that I shared where it's all about proportion. And if you could aim to consume 2/3 or more of plant foods on that plate, then you are off and running. And again, you're probably satisfying your requirements for your micronutrients, those vitamins and minerals, but you're also eating an abundance of cancer protective compounds. So let me speak a moment about those cancer protective compounds found in plant foods. And this is why you hear dietitians suggest that you eat the rainbow. I describe them as cancer's worst food enemies, all wrapped up in a single package. So from our whole grains to our beans, our lentils, our brightly colored fruits and vegetables, they are really bang for buck for cancer protection. And that's because they contain antioxidants, which have been shown to repair damaged cells. They contain a good amount of fiber that helps us to eliminate toxins and helps to control blood sugars. Those special compounds, phytochemicals, I'm going to speak about them next. And I also have a special note to say about vitamin D. So the power of plants in these phytochemicals, which literally mean plant chemicals, and there's over 10,000 of them that we know about. There's probably many, many more to be discovered. Well, these special compounds found only in plants help to stimulate the immune system. They block the production of carcinogens. They help to reduce inflammation. They prevent and repair DNA damage. They slow cancer cell growth. And they also reduce oxidation that might otherwise spur cancer. So this is really where it's at if you're looking for choices to help yourself along your journey. Now, I do want to speak for a moment about vitamin D. It's also known as the sunshine vitamin. That's because we make vitamin D from the UV rays that we're exposed to in the sun. And the experts want us to aim for about 600 to 800 international units daily. However, it is listed as a shortfall nutrient. That means Americans are not consuming enough of this precious vitamin in our food supply. And I'm going to speak about that in a moment. Now, vitamin D is exciting. Preliminary research shows that it inhibits renal cancer cell proliferation, angiogenesis, clonogenicity, and metastasis. Research has also shown that it induces cell differentiation. So it's more important than just bone health. We're seeing it has many other valuable functions. And this research study was published in 2014, so it's going back a little ways. But what the researchers found is that those individuals who had adequate levels of vitamin D in their body with kidney cancer, that it improved their survival. There's some relationship there. What they did point out is that those individuals who had low levels and those individuals who had high levels, that this was detrimental. This negatively impact their survival. So the bottom line and story on that one is that we just want the right amount. We don't want too high, we don't want too low. So a little bit more about vitamin D in the sunlight. A certain time of year, this is a map in the month of November, where the UVB starts to minimize, right? So we're not going to convert as much of that UVB light to vitamin D. And there's a line from Atlanta basically to LA, where above that line, especially during the cooler winter months, we are probably not making adequate amounts of vitamin D until the mid to late spring. Also, there are other factors that impact our ability to make vitamin D. If we have darker skin, if we're someone who wears a lot of sunscreen, we don't go out, we wear a lot of clothing, we're probably not making vitamin D from the sun. So then maybe you're asking, if I'm not getting it from the sun, how can I eat more vitamin D? Well, here's your top food sources in our diet. It comes from salmon, fortified products, including milk and the alternatives, as well as some cereals. Mushrooms who have been exposed to UV light, how cool is that? And then the whole egg. So vitamin D is actually contained in the yolk, and an argument to eat the whole egg. Now, the bottom line with vitamin D is that you need to just talk to your healthcare provider. Do you need to take a supplement or not? Don't just assume that you need an extra amount, okay? You can have your levels tested and have that recommendation given to you specifically, which is appropriate. And the other point I want to make about vitamin D is that keep in mind, no single food or nutrient alone will singularly protect you against cancer or protect you against progression. It's really the total diet that matters within a protective lifestyle. So these are the resources that I often share with individuals. The American Institute for Cancer Research, that's who have those great graphics. Cancer Nutrition Care, I'm a co-founder of that team, and we have some free screening tools right on our website. And you can also download the Essential Cancer Nutrition Care Toolkit for free. There's some great websites for recipes, including Cook for Your Life and the Cancer Support Community. And the American Cancer Society published What to Eat During Cancer Treatment, a cookbook, just a few years ago. And I think it was a great upgrade from their prior edition. And I often use it in cooking demonstrations. So in summary, I just want to remind everyone and raise awareness that nutrition is critical for every single stage of the cancer journey. Nutrition counseling from an expert can improve outcomes. Personalized nutrition is always superior to generalized advice. And last but not least, lifestyle matters. A whole food plant-based diet pattern, not just one food, that type of pattern saturates the body with cancer protective compounds, and that's what the experts advise for us. Here's my contact information. Please reach out to me anytime. I'd be happy to help. And I want to, again, thank you all for attending.
Hi guys, I am Jayla Barnes, one of the nurse practitioners involved with the Judy Nicholson Foundation. And I'm here with you this evening because we're going to talk about tools for coping. During the course of my time with the Judy Nicholson Foundation, I've met quite a few patients and families who have asked great questions. We've had great conversations about treatment plans and their medication regimen. But also what I find is that the caregivers and patients tend to have their own little tricks that they've learned over the course of time to handle different things that they encounter throughout the journey. Of course, anytime you're dealing with illness and cancer, of course, being one of the more chronic things that patients will encounter, what I find is that you learn little things along the way that help you. And so it's important feedback that I've heard that families find it helpful when we share some of the things that we've learned that have been helpful. So outside of talking about medication treatments and the chemo regimen and all of that itself, this particular video is going to focus on you as the patient and or family member and or caregiver. From time to time, I find that we also have providers that are interested in these discussions. And a lot of times that's because, believe it or not, we get attached too. And so what we find is that we have patients and loved ones who we want to support in various ways throughout that cancer and that treatment course and journey. So today we're going to talk about tools for coping. And I'll just give a little background about myself. I've been in the medical profession for almost 20 years. So topics like this are something near and dear to my heart because the patient, you're not our only concern or focus. Your family, whoever is an extension of you, they're an important part of that. So today I'm going to share with you a few things that I've learned, both from talking with patients and families to some of the research that we provide to families and their caregivers regarding tools for coping. So cancer diagnosis brings about an array of emotions, and you and your family members can definitely relate, as it likely is if you're a patient or a family member for someone going through treatment or who've recently been diagnosed with cancer. If you've ever had a loved one who was treated with and for cancer, then a lot of this is going to sound familiar to you. However, what I like to focus on is something we call the stages of grief, and there are 7 stages. I'd also like to clarify, grief is not just about death and dying. Grief will include the emotional turmoil that we sometimes find ourselves going through as we not only accept the cancer diagnosis, but also as you work through the treatment plan, the course of it, the changes in your daily life routine and cycle, but also anticipate whatever the unknown may be, milestones and things that will affect your family, and what some patients will say, this burden of now being a receiver of care instead of a provider in a lot of instances. So what's normal coping or grief, and what are some of the signs that we can look at as it relates to how to know what's normal and what's okay versus when there may be a time to seek counseling. And so a few techniques that we'll cover as well. So those are a few objectives. And we're going to also provide some strategies to coping with and dealing with those things. So coping, for one, is one's investment in their conscious effort to resolve or solve or figure out their own personal and interpersonal feelings. Where do you find yourself with hearing the word cancer and or now knowing what your treatment option or plan may be? That in and of itself is going to be a challenge because for a lot of people, I think just hearing the word in and of itself is a challenge. I've had patients that have told me, I knew something was off or not right for some time, but I was hoping it would just get normal or resolve on its own. And more times than not, what we're looking at there is the fear factor of, I'm hoping it's not something bad. And we hear that a lot too. I don't want to have bad news. I don't want to hear anything that's going to be a challenge to me. So emotional coping then is that psychosocial component, that part of us that has to then process and accept what we may potentially hear as it relates to that. So now let's review the normal coping mechanisms then. So those 7 stages I referred to: shock and denial, pain and guilt, anger and bargaining, depression, upward turn, reconstruction, and acceptance. So throughout these different phases, and again, though we're talking about it as it relates to hearing and the initial cancer diagnosis, because this can relate to both patients and families, but as well as the caregivers involved, the medical teams, think of it as the medical providers who are walking this journey with patients and families. These things will apply there too. It is always our hope to beat, to fix, to address everything that we come across. But there are also going to be times when we have to sit down and have those difficult conversations. So shock and denial, this then would be that stage or the phase where the disbelief, this can't be what's happening. This can't be, me. I've seen other loved ones go through this. How can this be possible? And that part of it, that shock and surprise value. From there, we move into what potentially is the pain and the guilt. If I had done this, if I checked this sooner, if I had eaten right, if I had done, we start to go through all the what ifs. And what we find with medicine and with research is while lifestyle can affect and influence or increase risk for cancer diagnosis, there's so many other things that go into that. And we have to find a way then to be at peace or to not get stuck in those areas where that becomes then an ongoing conflict for us. Anger and bargaining. This is where we tend to lash out at, it could be family members, it could be our physician, it could be our care teams. I've heard patients say, I've gone to my primary doctor, 3 or 4 times about this same thing, and they said everything was fine, only to then find later that a cancer diagnosis is there. With anger and bargaining, some patients and families will find that they are angry at God. Why would he let something like this happen? Why now? Why, because what I also find is these things also don't come at a time when you already are prepared for it. It's when a lot of other things are going on, and it can be yet another thing to add to your plate. And we're just not ready or wanting to hear this kind of information or to deal with that. Depression. While depression may not be to the furthest extent, situational depression can come and go. It can be, it usually is definitely related to the symptom or the issue that is going on at the time. And that could be whether it's something that lasts for a few days, or it could last for weeks to months, and occur throughout different times during your treatment course and the journey of dealing with your cancer diagnosis. So that period of isolation or loneliness, that period of reflection. There's a lot of different emotions that can be felt during this time, but a lot of times patients are not at a place where they'll talk about it. Caregivers, your family structure and dynamic changes quite often when a primary member of the care team or the family makeup is ill or unable to work or do their contribute their normal role to the family because of a cancer diagnosis and or treatment. And so that can change a lot of how they view themselves. And then caregivers can also go through these emotions or these phases, primarily because then they have to figure out then how do they still, how does that relationship dynamic change because of the diagnosis? The upward turn. Calm, relaxed state. This is sometimes some patients will call this, I just kind of got numb. After a while, I felt numb. I heard the information. I didn't really, what else can you tell me? I've gotten to this point, some unfortunate news, and nothing can surprise me at this point. We hear things like that. So while you're not totally accepting of the diagnosis at this point, again, it's more like a numbing phase where you almost expect not so much good or bad news, but you just know this is now you're in the plateau or the middle phase of your treatment course, your plan, your grief, your emotions, all of it. You've come to a place where you're hearing it, you expect certain parts and information, but you're kind of ambivalent in a lot of time, in a lot of instances. So then the next one is reconstruction and working through. This phase is where we aren't totally at acceptance yet, but we're starting to say the what if this is in fact going to be a journey, whether we are seeing positive signs from the treatment plan that's in place, if there is some hope or plan or thought of recovery or remission, or if not, what would that look like? While I'm going through treatment, I can't work, I can't do house chores the way I normally could. We need to now define workarounds of whether it's regarding picking up the children, who's going to mow the lawn, how do we get the things accomplished or done that the caregiver can't physically do or can't absorb or pick up any more tasks, but also the patient can't right now then fulfill those expectations either. So you start planning, how do we work around this situation? And then acceptance and hope. Acceptance is, this is where we are. Whether we're seeing positive outcomes from treatment, whether we've elected to do treatment, surgery, whatever that next step is, we're taking it on full steam ahead, full well knowing that there's still a lot of variables here, but we're at a stage, we're in that phase where we're wanting to then see how to get to that next point. And so acceptance and hope go hand in hand. And hope is not just one phase or one avenue. Hope changes over the course of care. And I tell patients, I hope my pain is managed. I hope my family can join me for some of my sessions. I hope that I can do one cycle and not have to do repeated or recurrent cycles. I hope that next month I am well enough and have the energy to be able to participate in a family event. So hope then becomes more normalized over the course of this phase. And again, Does that not mean, though, at some point you may not revisit some of these phases? Will they always go specifically in this order? The order is pretty consistent. However, as you move from one phase to the next, what you may find is what you're grieving may change. So if you find that you're going through that cycle again, it's not so much that you've gone back to the drawing board, but there's new pieces of this puzzle that, as it unfolds, will lead you to revisit various stages of grief, because grief is about not about death and dying, but I'm grieving a change or some kind of normalcy, or I'm grieving the change in my role, or I'm grieving what I can't do right now, what I used to be able to do, and those dynamics that are still evolving. And again, uncertainty is a lot of time the biggest one that I hear, just the unknown. Here are a few things. I said this is tips and tools for coping. So we spent a good bit of time defining what the coping stages and grief stages are, because that's usually where we find that the struggle is. So some of the tips for dealing with the anger and the frustration that comes along with at different times. And again, this is both patient and caregiver. What we find is that, and some of these will sound trivial or simple, but I promise you, these are both from feedback that families and patients have shared, but also this is research and literature based, okay? So countdown, that sounds very trivial and you hear it all the time, but start from 100 and count your way backwards. You may make it all the way to one, or you may find that by the time you get to 60 or maybe 90, maybe it doesn't take you as long. Take a breather, walk away from the things that right now are causing or adding to your stress. If it's a situation you know you need to face, you'll come back to it. So we're not avoiding or abandoning that part of the conversation, but step away and come back. And a lot of times that'll give you a clearer head. Go for a walk, same thing. Exercise, massage. We are mind, body, and spirit. And what we don't want to underestimate is how much our spiritual or our psyche plays into how our body's relaxation is tied into sometimes what physical touch may be linked to. Some patients and families say music therapy has been key for them. Some will say pet therapy, retail therapy, shopping, that we have to be careful with that. But find you some mantras, some positive affirmations. Music therapy again, end or defer conversations that are going to be difficult for you. This is where, though you need certain conversations to happen, I would say it's definitely helpful to have designated a person that you feel you can be very candid with, because there are going to be times when you're going to want to hear, this isn't fair, and I am upset, and I don't like the information that I've received, and I'm not happy right now. I don't like what's going on. And those are all honest feelings that you should be able to both express with your families, with your physician team, because if you're pinning that up, at some point that emotion is going to need to be shared. And some people find it easier to write it down, whether you're just writing out your feelings. You may ball it up and throw it away. You may write it in letter form and present it to someone. I've even had patients that have shared drawings and paintings and poems and things that they've developed. So creativity can play a big role in that. Again, removing yourself from upsetting situations. This may not be the doctor's office conversation or the family conversation. You may find that out of the blue, you're out in public and something for some reason is triggering a feeling or an emotion that you didn't expect. And it's okay to identify that situation is upsetting to you and for you, and to excuse yourself so that you can relax, revamp, readjust, or just go to a quiet place and allow your emotion or your feeling to be what it is. And it's okay to feel what you feel, but at some point you've got to come back though and still express and talk. You don't want to ever totally wall off from others. So it's important that you find a support group and friends and family that you can talk to. There are some community resources that can be helpful to allow you to be amongst people who are going through similar situations as you. They've either come through on the other side, and it can be helpful in giving you tips and sharing things that help them cope along the way. And again, this applies both to families as well as patients, okay? Caregivers, your support team, because they're going to need it as well. find things that make you laugh. It's okay to laugh and to still have good memories and good things occurring during the course of your treatment, and just, as these feelings and emotions come and go. Practice gratitude. Again, writing letters and cards to families and friends, that's going to be a huge one. I also encourage patients, because we do encounter families and patients who are not doing well and who have not gotten a great update, whose prognosis may be that their health is failing or that they could be entering the dying phase of life. And for those particular patients specifically, but families as well, the patient tends to then think about the milestones and things that they will miss or that they may not be here for. And what I say is, write letters, write out cards, graduation presents, first child, weddings, things like that, so that you're able to share your sentiments. Because one thing is for certain, if you do that, your loved one then has that to cherish. And if your prognosis is extended or your status improves, you'll be here to share those memories together and still reflect on what those notes may include. So then a book that I would recommend then too is something called 4 Things That Matter Most. It's by Ira Brock. It talks about the I love you, I thank you, forgive me, I forgive you, and just kind of walks that journey of then how do we get some cleansing so that we feel that we have been open and honest and can get some expressions out there. Practice empathy. Practice empathy. Though you're going through a lot, don't ever underestimate too, though your situation is whatever it is, but there's other people around you too that may be going through things. And sometimes in support groups and in family situations, or just in your friend group, you may acknowledge that others are going through as well, and you'll be surprised. I'll share that with patients as well who say, I volunteer at different places because as I go through my journey, I know I can share things with others. And so they do that. And then express your anger. I mentioned that earlier. It's okay to say, I'm upset, I'm not happy, I don't like this news. Because the more you get that out and the sooner you say that, the hope is that you aren't stuck there. The hope is in the family support and for others to hear and know how you feel about that situation or just your emotions at the time. Hopefully will allow you then to be able to get to the support of your inner core group, whether that's your family, friends, or support team, and or your physician team as well. Because again, most physician offices should have a dynamic where there's social worker support, nursing support, not just the physician team that's providing your care. Another peek at the stages of grief and some of the things that can go along with it: shock, hearing the bad news, denial, trying to avoid the inevitable frustration or anger, the frustration of outpouring of emotions, that roller coaster of emotions, depression, bargaining, seeking out seeking in vain for a way out, wishing it could just go away. And of course, we know that's, it's not that simple. Depression, realizing the inevitable, testing, seeking for realistic solutions, and then acceptance. Finally, getting to a place where you can move forward and develop plans with your family. All right. So again, I think throughout the course of this discussion, I did mention that there are family and caregiver support groups. While these are things you can do together, I do think it's important to do these things separately too when you can, because as caregivers, what I find is patients and caregivers do one or two things. You've had discussions before because of another family or friend or some other experience that allowed you to be comfortable having these difficult conversations, not just about your emotions and these various stages we've discussed, but what your wishes are. If I absolutely don't respond well to treatment, if I don't get better, these are the things that it's important for me to have you know. This is where it's important for you to tell your physician how you want to be communicated to and with, how honest and upfront, or do you need a little more sugar coating with the information as they deliver it? Is there a patient or family member that you want present when you have these big discussions? Have you put your wishes and things in writing? Meaning, have you done a healthcare surrogate or a living will? And living wills aren't so much about your financial affairs as it is what's important for someone to know about you if they ever had to make medical decisions for you. This is where those support groups can help you anticipate and plan for these future discussions, but also have candid conversations with people who are actively going through similar situations or who have been through it and are clinically trained to help you get through these situations or these times as well. I hope this information has been informative and helpful for you and your loved ones. Please visit the Judy Nicholson Kidney Cancer Foundation support group page and or their social media sites. There's plenty of information and resources there available to you, and we are definitely available to continue to support you in whatever way we can. Thank you again, and I hope this was helpful.
Hello, hello.
Hi, Jayla, how are you? And hi, Lauren.
I'm doing well, thank you.
Good morning and good afternoon.
Hello, how are you?
Doing well, how are you?
Awesome, I'm doing well, thank you so much. Thank you so much. And welcome everybody. It looks like we have quite a few still on today.
We do. We got some people who stayed on to the end. They wanted to make
Awesome.
sure that they heard from y'all. If anybody has any questions, please don't hesitate to type them into the chat. We'll be happy to answer your questions here.
Hopefully this information has been informative. I know that it can be overwhelming and a lot of information at once. So hopefully instead of it just being printed material, the videos are helpful to kind of make it relevant to you. And anything else we can answer or ask or prepare for you in the future, that's helpful information as well.
And we certainly, at the foundation, we certainly appreciate both of you dedicating your time to putting together these talks for us. I know a lot of people get a lot out of this from the video library that we have on the Judy Nicholson website. And so if we don't get any questions today, I'm sure that some will follow in the comments section in the future. Karen had a comment, excellent symposium. She said, thank you so much, Karen. I really appreciate you coming in today.
Awesome. Awesome. Thank you, Karen, for that feedback.
And Jan, I really appreciate your comments as well. I really appreciate you coming to the symposium today and hanging out with us. And if anybody would like to share this information, it'll be on our website in the coming days. So you guys can, if you missed any part of this symposium, you can check it out there.
That's always so helpful too, right? That it's recorded so everyone can go back to it, because I'm sure there was a ton of information and helpful information that was presented. So that's so wonderful.
It certainly helps people not have to scribble notes in the middle of it, and knowing that they can always refer back to it.
Yeah.
Perfect. Well, definitely there'll be more to come. There's always new topics or information or new inquiries that we get along the way. So whatever else we can do to be helpful, we are here.
All right, y'all. Appreciate y'all both stopping in. And if anyone does have questions coming forward, don't hesitate to reach out to us on social media or through our email at the Judy Nicholson Foundation at gmail.com. We are happy to provide answers today, tomorrow, or whenever. So thanks everyone for joining us today, and I look forward to the next one.
And with that, our symposium has now come to a close. We hope that you have found the last few hours useful in improving your knowledge about the diagnosis, staging, and treatment options of kidney cancer, as well as the nutritional and coping strategies available to patients. I want to personally thank all of the presenters today who took the time out of their busy schedules and volunteered their resources, experience, and effort in composing their respective slides and presentations. I also want to thank the Judy Nicholson Kidney Cancer Foundation for their hard work and dedication in providing support and education to kidney cancer patients and their caregivers. They do a great job. And most importantly, I want to thank our patients and their families for trusting us with their care and participating and enrolling in our clinical trials. While we have come a long way in improving the care of patients with kidney cancer, we still have a long ways to go. Thank you all for tuning in today, and I wish you all the best of health. Stay safe.